morning. Welcome to the Bloomberg American Health Summit. Please take your seats. Our program will begin in 10 minutes. Thank you. Good morning. Please take your seats. Our program will begin in 5 minutes. Thank you. take your seats and silence all electronics. Our program is about to begin. Thank you.
Good morning, everyone. I'm Brian Fitzy, and my colleagues and I are pleased to have been asked to open the session this morning. Can you all hear me okay?
Yeah, I can hear you.
Great. Shakina?
You're on mute.
You're on mute, Shakina.
So sorry. You'd think this was my first Zoom. Good morning, everybody. Look, we all know this is a daunting moment for health in America. So many challenges. We really need to find a reason for optimism.
That is so true. But I know a good one. The group gathering in Philadelphia this morning. All the fellows, staff, and faculty of the Bloomberg American Health Initiative.
You're so right, Brian. These folks are on the front lines of America's health challenges. They've struggled through the pandemic, and they're ready to keep pushing for change. I know this summit is going to be really interesting and especially inspiring.
Agreed. It might actually be the best day the initiative's ever had. I wish we could be there. Wait, why can't we be there? Why can't we be there? Enough with this Zoom call. The only way this works is if we're all there together. Let's get out there.
Well, hello, it's great to be here. You look even better in person. Welcome to Philadelphia. It's gonna be a great day, isn't it? Yeah?
Hey!
Hey, Shakina! I had a dream so big and loud, I jumped so high, I touched the clouds. Whoa, oh, 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 oh. Whoa, oh, 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 oh.
I stretched my arms out to the sky, we danced with monsters through the night. Whoa, oh, 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 oh.
Whoa, oh, 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 oh. I'm never gonna look back, no, I'm never gonna give it up. Whoa, please don't wake me now.
2, 3, 4.
This is gonna be the best day of my life.
My life.
This is gonna be the best day of my life.
My life.
Hello from Clingit Land in Sadiqa, Alaska. I hope this year's summit brings you laughter, connection, and a renewed spirit for all the amazing work you do.
Aloha, fellows. I hope you all are having a great time at the summit.
Greetings, everyone. I really look forward to seeing the great work that comes out of this meeting.
I howled at the moon with friends, and then the sun comes crashing in. Oh, 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 oh.
But all those possibilities, no limits, just epiphanies. Whoa, oh, 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 oh. Whoa, oh, 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 oh.
I'm Camille with Duke Health, and we are so excited to be here as fellow and collaborating organization.
Hi, I'm Maureen, a Bloomberg Fellow with Local Environmental Agriculture Project. I'm so excited to be here.
2, 3, 4. This is gonna be the best day of my life.
My life.
This is gonna be the best day of my life.
My life.
Working together, we will build a better future for our nation's health. Thank you for all that you do to support public health.
All right, here's what we're gonna do right here. Let's hear you do it with us. Come on, ready? Come on.
Put your hands together.
Come on. Louder, louder. Here's the numbers. Let's take this thing home. 2, 3, 4. This is gonna be the best day of my life.
of the Bloomberg American Health Initiative, Dr. Joshua Sharfstein and Michelle Spencer.
All right.
Okay, that was incredible. I've never seen anything like that before.
You think?
Michelle, what would you even call that?
Now that is what I would call a hybrid meeting.
Okay. Well, that's the best hybrid meeting I've ever been to.
Good morning. Welcome, 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 welcome to the 5th annual Bloomberg American Health Summit. And let's hear it for our fantastic Philadelphia-based artists, Brian Fritzy and Sadiqa B.
We've got a few to go through here. J Flo, Andy Meyer, and Glenn Hale.
Woo woo! How about the singers from UPenn's Off the Beat and dancers from Just Soul?
Artists from the Philadelphia School of Circus Arts and young musicians from the School of Rock and Rock to the Future.
And actual mummers from the Woodland String Band. Josh, let me say, it's great to be back in person, isn't it? We're so happy to see so many fellows, so many faculty, so many partners, so many.
So many people, all in one place. I'm excited and a bit overwhelmed at the same time.
Well, isn't that the story of the last 5 years? Exciting and yet a bit overwhelming?
Well, you remember our first summit in 2018? The Bloomberg American Health Initiative had launched 2 years earlier at a period of stagnating life expectancy, with the goal of using public health tools to confront some of the nation's leading health challenges.
Violence, addiction, the environment, obesity and the food system, adolescent health.
We enrolled fellows, welcomed their organizations, funded projects, provided support to faculty. We held 2 in-person annual summits before the pandemic struck.
And then suddenly, all of our lives depended on public health tools, vaccines and treatments, but also epidemiology, partnerships with communities, and communication.
The pandemic revealed how profoundly health challenges threaten the nation and how deeply the roots of those challenges reach. The past and present of inequity, racism, and political polarization have cost so many lives, not just from COVID, but also from overdose, homicide, suicide, and other causes.
And it has been a bit overwhelming. In many places, public health became a scapegoat and a punching bag. Our worlds were flooded with misinformation, even as our work mattered even more.
But we persisted, acknowledging our mistakes, brushing ourselves off, checking the evidence, moving forward and saving lives. And I know from just the last couple of days how many great people who have done just that are in this room.
Well, which brings us to today. The Bloomberg American Health Initiative now has 269 fellows. You all represent 239 partner organizations in communities all across our country. We are on location, and today we see you, and we appreciate you.
And that's why we're trying to make this event just a little bit different than the usual public health meeting. Okay, now, as part of that, to see whether we're succeeding, there will be a series of surveys. We're going to do the first one now. It's going to be a 300-question Likert scale up to 5.
Yeah.
They're coming from the side. They'll be distributed with the pencils.
I like the Likert scale, right? All public health, all NPH, all DRPH, everybody's doing biostats and epi. But we are not doing that. There's not going to be a 300-page survey, right? Maybe that's for some other public health conference, but not for us, not for today. We, I think, are succeeding already. Don't you all agree?
No survey?
No, it's not necessary. No survey.
Okay, all right. So this morning, instead of a survey, we are going to be hearing from political leaders, from health commissioners, from experts, from community members doing incredible work.
Over the next 2 days, we'll make connections. We'll chart new paths to impact. We'll recharge our batteries for the critical year that is ahead.
We'd like to thank Mike Bloomberg and Bloomberg Philanthropies for the incredible support to make today and the initiative possible.
Thank you to our Dean, Ellen MacKenzie, to our Dean, Ellen, to our fellows, to our team members, the faculty at the Johns Hopkins Bloomberg School of Public Health, where the initiatives lives.
And we'd like to thank everyone at Johns Hopkins for their support and leadership during the pandemic and beyond.
And now it is my pleasure.
It's our pleasure.
It's our pleasure.
Yeah.
My pleasure.
Yeah.
Our pleasure? Okay. It is our pleasure to introduce the president of Johns Hopkins University, Ron Daniels.
It's like Oprah.
Yeah.
Kind of feels like a talk show. I've always wanted to be a talk show host, and this may well be as close as I get. Good morning. After 2 years of exclusively virtual summits, I share Josh and Michelle's delight that we're able to gather here in person and on location in Philadelphia. This is, in fact, no small detail. Place matters, especially for public health. Indeed, this has been true since the origins of the field. In 1854, a cholera outbreak in London's Soho neighborhood claimed more than 500 lives in 10 days. Now, this devastating loss compelled a local physician named John Snow to leap into action. And he went local, hyper-local. His first step was to create a map of all the cholera deaths. Once he had visualized the data, the culprit became clearly apparent. All the deaths were clustered or connected with one particular water pump in the neighborhood. Now, Dr. Snow informed the health board, the pump was shuttered, and the outbreak was contained. 166 years later, in 2020, and you know the story, a graduate student at Johns Hopkins in Baltimore began noticing that people in his home country of China, indeed in Wuhan, were beginning to get sick from a mysterious illness. He worried for his family, and working alongside his mentor, Hopkins engineering professor Lauren Gardner, they set about creating a map of infections just like Dr. Snow had before them. As COVID-19 spread, so did the map, eventually reaching a global scale that Snow could have hardly imagined in informing public health decisions around the globe. But this work, once began with a deep concern and profound concern for the lives and well-being of specific people in a particular place. Place matters. This insistence on the importance of place has been at the heart of the Bloomberg American Health Initiative since it was launched in 2016. From the beginning, the initiative has aimed to bridge cutting-edge academic research with on-the-ground knowledge and expertise of public health practitioners in communities across the country to tackle our nation's greatest public health challenges. Mike Bloomberg and the entire Bloomberg Philanthropies team understand, as we at Johns Hopkins do, that public health work is most successful when it is informed by and responsive to the habits, needs, and experiences of the populations being served. Today, our Bloomberg American Health Initiative faculty, fellows, and students are working together to fulfill this ideal for the good of our world and all our communities, from Philadelphia, Pennsylvania, to Poplar, Montana, and points in between. They are tackling environmental degradation, addiction, violence, health problems facing adolescents, and obesity. It has been truly an incredible journey so far as the Bloomberg American Health Initiative has built the foundation for the future of public health in the 21st century. And for the story of how this initiative started and how it's growing, please take a look. Roll film.
The nation's opioid epidemic has never been deadlier.
We have a 20% dropout rate. It's one of the highest in the developed world.
90% breathes unsafe air.
More than 42 million people in the U.S. go to bed hungry each
Gun
night.
accidents killed at least one child in the United States every other day.
In COVID cases here in the U.S.
Hospitals are in crisis, is dealing with the worst pandemic in a century.
Devastating decline in the mental health of kids.
Now more Americans dead than in 4 years of battle during World War II.
Please welcome Bloomberg Fellow, Boston Medical Center and Boston University School of Medicine, Dr. Sadiqa Kendi.
Good morning, everyone. I think we all believe in the message we just heard in the video. No matter how good today is, tomorrow can be even brighter. And that's why we're dedicating our lives to public health. My name is Dr. Sadiqa Kendi. I'm a Bloomberg Fellow based in Boston, and my work is dedicated to injury prevention and health equity, ensuring that all children have access to the human right of health and safety everywhere. The urgency I feel doing this work each day is one that I know you feel too. And it's an urgency that, for decades, has also driven the public service and philanthropy of our next speaker. He was born and raised in Massachusetts, just down the street from where I currently work. Later, he chose a school in Baltimore, and President Daniels and all of the Bloomberg Fellows are very glad that he did. Working his way through college, Mike Bloomberg graduated from Johns Hopkins University. Building on the $5 he donated to Hopkins that year, he has given generously to his alma mater ever since, both financially, but also his time and energy. The public health school was renamed for him even before he won a long shot campaign for mayor of New York City. And as mayor, Mike implemented ambitious public health programs that made him an international leader in the field. Most recently, Mike was reappointed as World Health Organization Global Ambassador for Non-Communicable Diseases and Injuries. His foundation, Bloomberg Philanthropies, continues to make major global investments in life-saving initiatives to reduce tobacco and e-cigarette use, support healthy food policy, increase road safety, which is near and dear to my heart, improve maternal health, and more. And in 2016, as part of the Public Health School Centennial, he launched the Bloomberg American Health Initiative to help train the public health workforce of tomorrow, which brings us all to today. Please join me now in welcoming the 108th Mayor of New York City, our partner in public health, and the initiative's biggest fan, Mike Bloomberg.
Thank you. Thank you. Well, good morning, everyone. What a crowd. Dr. Kendi, thank you for that kind introduction. You gave it just the way I wrote it, so thank you. And thank you, Ron, Josh, and Michelle. And it was great to see Dean MacKenzie here earlier. I think it's the most appropriate way we could possibly have to start the morning with all the talent we have assembled on location here in Philadelphia. And I want to thank all of you, the followers, fellows, faculty, and staff of the Bloomberg American Health Initiative. Your work isn't always glamorous, and often it can be thankless. I know you didn't choose this field to receive fame or fortune, and if you did, sorry about that. But I do think that all of you deserve a special round of applause. Give yourself one right now. Back when I was a student at Johns Hopkins and my objective was to make the top half of the class possible, something that I certainly succeeded at, I want to thank Ron Daniels for not revealing that I was a C student, but I did study engineering, and I never thought that the public health school would someday bear my name, and I can assure you that my professors did not either. None of them are alive today, but that's what they would say. Public health has been a passion of mine for a very long time. I first caught the bug one night over dinner with your former dean, who's here today, Dr. Al Sommer, who we're glad to have on the board of Bloomberg Philanthropies. And by the time dessert arrived, Al had made me a true believer, so it was a great dinner. He couldn't have had a great career in sales. He could have had a great career in sales if public health hadn't worked out, but he's the one that convinced me and deserves the credit for all of this. Al, thank you. A few years later, when I was elected mayor of New York, I didn't need a crash course in how effective public health policy could be. Our administration took on smoking and trans fats and sugar, and we did it with science, data, and facts. And in each case, we faced strong industry opposition. But we beat them on tobacco and trans fats, and here in Philadelphia, Mayor Kendi is showing that you can beat them on sugar as well. Yes, all right. Back in 2016, Philadelphia adopted a 1.5 cents per ounce soda tax, and when the industry tried to overturn it, the mayor didn't back down, and we were with him every step of the way. And together we beat the industry, and the people of Philadelphia are winners because the tax is working. Philadelphia has seen a 35% decline in sugary drink sales since the tax was executed, which means it's already helping to save countless of lives. The mayor and the city's health commissioner, Dr. Cheryl Bedagol, have helped make Philadelphia a national leader on food policy, and we're glad to have her with us today. Nice round of applause for her. Last month, we saw another major victory for public health, this time in California. The e-cigarette industry tried to overturn that state's ban on flavored tobacco products, but people said no ways. They fought back, and I was glad to support them. And once again, the tobacco industry lost, and the public health won. And once again, it will help save millions of lives. So we're proving that it really is possible to defeat the special interests at the ballot box, because when you have the facts on your side and you communicate them clearly, most times, not always, but most times, the public will support you. And that's why we're raising awareness of your work that is crucial to your success. At Bloomberg Philanthropies, we work to shine a much-deserved spotlight on public health. And one way that we're doing that is with a new documentary series coming soon to a screen near you. And today you have a special peek, way ahead of everybody else. So just take a quick look.
Public health saved your life today, but you didn't even know it.
Our team is one of the best in the country.
Public health has almost always been invisible. Then you have a pandemic. And in the pandemic, that invisibility is gone, and it's not coming back. We need to tell the story of public health.
Public health has been protecting us since the Black Death.
There was a time when you went to work, it wasn't clear if you were going to come home from work.
2 centuries ago, 1/3 of your kids were likely to die in childhood. Now, childhood is the safest time of your life.
Public health is my calling. It's a call to humanity and a call to service.
In the last century, we gained 30 years of life expectancy due to public health.
Life expectancy in New York City increased by 3 years with our policies.
To me, extending our lives is the most impressive thing that we have ever done as a species.
If everything's working well, nobody thinks about public health.
We have an invisibility crisis in public health, and it impacts our ability to be appropriately resourced.
Public health has been undervalued, underfunded, and misunderstood, and that hurts our health.
In 2017, we began to see a decline in life expectancy. That is a bad sign for our society.
Public health is like the foundation of your house. And let me tell you, ours is cracked.
Well, as you saw, the series is called The Invisible Shield. And when it's released, we hope to spread the word because more people need to know about the miracles of public health and what makes possible every day and the extraordinary challenges that we face. One of the biggest, of course, remains COVID. COVID has been the worst public health crisis the world has faced in a very long time. But we also know the pandemic only intensifies fires that have been burning for a long time. The problems that were here before the pandemic included all the non-communicable diseases that are leading causes of death, and they're still here, and they're still getting worse. Sadly, nowheres are they getting worse than right here in the United States, even though we thought all the tools we needed we had to prevent them, except, unfortunately, one, political courage. You've heard of American exceptionalism, the idea that America is unlike any other nation. Well, when it comes to communicable diseases, commitment to advancing freedom and democracy in the world, there's a truth to that idea. But there's also, sadly, a dark side of American exceptionalism, and it's staring us right in the face, even though many elected officials don't want to see it. So I thought this morning we could take a quick trip around the world, going on location, if you will, to see just how exceptional we really are and how far we have to go just to catch up with the rest of the developing world. For starters, we have a gun homicide rate 26 times higher than that of other high-income countries. 26 times. That certainly is exceptional. And the United States also accounts for more than a third of gun suicides globally. Think about that. We're about 4% of the world's population, but 35% of global gun suicides. And think about how many of those suicides are young people and all the promise and potential our country is losing from their deaths. All of us pray that our families won't be the victims, because the fact is it could happen to any family, and every day, 119 times a day, it does. Our child and adolescent suicide rate ranks in the top half of developed countries. That's heartbreaking if you think about it. But of course, it's not just gun violence prevention and suicide prevention where we rank so low in the world. Oh no. Among peer nations, we also have the highest rate of drug overdose deaths, more than 100,000 deaths last year, an all-time high. And the bad news keeps coming. A major risk for heart disease is obesity, and the U.S. is the most obese, large, developed nation in the world. That's killing people far before their time. Add it all up, and due to a combination of these factors and more, I'm sorry to report that the United States is not at the top of the list when it comes to life expectancy in the developed world, nor do we rank in the top 10, or the top 20, or even the top 30. We are number 40. We actually trail 39 countries in life expectancy. So in the greatest and wealthiest and most powerful country in the world, we rank 40th in the area that matters most, staying alive. That is a national embarrassment, and we're all here today because we refuse to accept it, and because we know progress is possible. And we saw that in New York City. When people ask me which accomplishment I'm most proud of from my time in City Hall, I usually cite the same statistic Kelly Henning mentioned in the video. Over our 12 years in office, life expectancy in New York grew by more than 3 years, which was 2 years longer than the national average. Back then, a lot of people thought continued progress was inevitable. After all, life expectancy had been on a steady upward trajectory for decades, as you can see in this chart. But of course, progress wasn't inevitable. It never is. And when national life expectancy began to stagnate and decline for the first time in a century, I just couldn't sit back and watch it happen, especially since the federal government wasn't doing much about it. That's how this initiative was born. And we worked with a team at Hopkins to design it around a principle that has been so important to our work in New York City: collaboration and partnership across agencies and fields. Part of the genius of the Bloomberg American Health Initiative, if I may say so, is your commitment to working across disciplines, because it really does open up new avenues for change, and it yet is so rarely happens. The good news is the challenges we face are not insurmountable. After all, history of American public health is filled with extraordinary successes. Anyone who buckled a seatbelt this morning, or who ate breakfast without trans fats, or sat in a smoke-free diner, has benefited from public health initiatives, even if they don't realize it. But as we know, we are not moving fast enough. To help accelerate our progress, the Bloomberg American Health Initiative is releasing a new report today called Reversing the Decline. The document offers 10 practical steps for addressing underlying causes of the biggest contributing factors to declining life expectancy. Those 10 steps include making sure medications to treat opioid use are the standard of care in all medical settings, and enacting stronger gun safety laws, among others. I'll add one more step, because most of the other 10 won't happen without it. Call your member of Congress and other elected officials and tell them to stop protecting special interest in industries that start protecting us instead, or we're going to vote them out of office and replace them with people who will. The one thing they care about is being able to feed their families. They've got to keep their job, so getting reelected is more important than protecting you. You've got to turn that equation around and make them understand that protecting you is the ways that they're going to get elected, and if not, we're going to damn well work for whoever runs against them, no matter how good or how bad that person is. It's time for the Congress people and the senators to stand up. I'm glad to say that several of the report's authors have joined us today. They are professors at the Hopkins Bloomberg School of Public Health, and I'd like each of them to stand or raise a hand because they all deserve a round of applause. Well, thank you, professors, and all the faculty and fellows for the great work that you do every day. There are countless infants, toddlers, teens, and 20-somethings, and parents and grandparents who all owe their lives to the work that you are doing. They may not realize it, but I hope it's something you think about every day, because thanks to all of you, tomorrow is going to be better than today for millions of people. So keep up the great work, and thank you. Thank you very much. Now, you've got a full agenda today. Later you'll hear from my good friend, the former mayor of Philadelphia, Michael Nutter, the director of the CDC, Rochelle Walensky, and the governor of New Mexico, Michelle Lujan Grisham. But first, it is my pleasure to turn it over to a partner who we'd worked closely with at Bloomberg Philanthropies, Josh Shapiro. As State Attorney General, he's been a leader in the fight against illegal guns and the opioid crisis and climate change. For some reason, voters elected him governor instead of an election-denying QAnon supporter. But it was great to see that he wasn't especially close either, the contest. The fact is that he's here today with us. It says a lot about his commitment to public health and his commitment to make us and our families live longer, healthier lives. So please join me in welcoming a friend and partner, the governor-elect of Pennsylvania, Josh Shapiro.
How are you? Thrilled to be here. Thanks for having me. Feels good. Good advice. Good morning, everyone. It is wonderful to be with you all today. Mr. Mayor, thank you for including me, and thank you for choosing to have this health summit right here in the Commonwealth of Pennsylvania, in the city of brotherly love and sisterly affection, the home of the 11-1 Eagles, Philadelphia. We are proud that this American Health Summit is being held here in Pennsylvania. And I'm especially proud to have the opportunity to address all of you, the folks who are doing the meaningful, results-oriented work in our communities day in and day out. I'm pleased you're here, and I'm pleased that we'll have the opportunity to learn from one another. I hope over the next few days that you'll be able to meet some of the community leaders and policymakers right here in Philadelphia, those who are doing the hard work every day to make our community safer and healthier and more prosperous. And I hope that folks here have the chance to learn from each of you so that we can improve our communities across the Keystone State. You know, our democracy was born right here in Philadelphia, just a few blocks from where we sit this morning. The story of our American democracy is one where we take a few steps forward and then we take a step back. But the trueness and the greatness of this American story is that we always make forward progress. We always advance the ball, and we always leave the next generation a bit better off than the way we found this nation. Forward progress being made by ordinary Americans, rising up, demanding more, seeking justice, looking for a better future for all. You are part of writing this next chapter in our American story. And while the foundation of our American democracy, the right to vote, has been tested, it certainly was in this last governor's race, and I'm not naive enough to think that those tests are over. So is the basic health of our citizens. That basic health is critical to the American democracy. It's a foundational principle of our society to make sure that everyone has a shot to live a good and healthy life. Strong public health, in my mind, equals a strong democracy. And that is what we are all striving toward, what we are all working for, what we are all building, what we can all learn from right here in the birthplace of our democracy. Right now, in the wake of the COVID-19 pandemic, I know it might feel like we're in the midst of one of those chapters where we've gotten knocked back from a public health perspective. Well, in the last 3 years, we've seen life expectancy in the United States decline faster than at any point over the last century. As the CDC reported earlier this year, Americans' life expectancy today is actually 3 years shorter than it was back in just 2019. And we know that, sadly, that drop is even worse in Black and Latino communities here in Pennsylvania and across this country. And while the pandemic obviously contributed to this decline, there are many other reasons. And as Pennsylvania's Attorney General, I've witnessed some of those challenges firsthand. I'd like to spend a few moments talking about 3 of those things contributing to the real challenges that we face today. I've seen the toll of the opioid epidemic in Pennsylvania, from right here in Philly to all the way out in the southwestern rural communities of Greene County in Pennsylvania. An opioid epidemic that claims the lives of 15 Pennsylvanians each and every day. It's one of the reasons why the Office of Attorney General has arrested 8,200 drug dealers in our communities. But I'm the first Attorney General who has said over and over and over again that drug addiction is a disease, not a crime, and it needs to be treated that way. I also believe that the drug crisis that we see on our street corners, it wasn't manufactured on our street corners. No, it was manufactured by the greed in pharmaceutical executive boardrooms. And that is why, in addition to making those arrests in our communities, I led a nationwide effort of other attorneys general around the country, Democrats and Republicans, to finally hold those pharmaceutical companies accountable for the role that they played in this crisis that claims the lives of 15 Pennsylvanians every single day. And we were able to announce an historic settlement about a year ago, one that's going to bring $28 billion back to the states, including over $1 billion right here in Pennsylvania. But unlike the tobacco settlement fund from years ago, we guaranteed as part of this settlement that each and every dollar from the settlement must go to treatment and related services in our communities. And so you come here to Pennsylvania and in your states at a critically important time when it comes to battling this opioid crisis, because this is a moment where we have real resources to be able to address the need, to be able to save lives, to be able to be compassionate. And while we need to make sure our criminal justice system is married up with our treatment community, we must make sure we approach this problem with compassion and with an eye toward treatment for those who are battling the disease of addiction. In addition to the opioid crisis, which claims far too many lives every day, gun violence continues to take a brutal toll on communities here in Pennsylvania and across this country. I applaud Mayor Bloomberg for his extraordinary work in this area, though he would be the first to admit that a lot more needs to be done. We have both visited too many grieving families who've lost a loved one to gun violence, or met too many children who live every day with the trauma of seeing gun violence in their communities. I believe that the gun violence epidemic should be considered a public health crisis in this country, and we need to treat it that way. I was recently at Jay Cook Elementary School. It's an elementary school in North Philadelphia. If you drive toward Temple University up Broad Street, you'll see the school just off of Broad Street. Spoke to a group of 4th and 5th graders that day. I was invited to talk about government, how a bill becomes a law, the basic stuff. And as I was leaving this classroom of 4th and 5th graders, primarily Black and Latino students, the teacher asked if I would stick around for just a second. She looked at the class and said, "Hey, class, tell the Attorney General," and by the way, I don't think any of them knew what the heck an Attorney General is, but tell the Attorney General if you've ever heard gunshots. Now, my kids and I live probably 20 minutes from this school. My kids have never heard gunshots. Every single hand went up in that classroom. Then asked the children, "Do you know someone who's been shot?" Nearly 75% of the kids raised their hand in that classroom. We have to acknowledge that these children are living with real trauma every single day. We can't just expect them to go to school and learn if we're not treating the trauma that they're dealing with in their communities day in and day out. And so while there's an important role for law enforcement to play, to get those who are wreaking havoc on our streets off our streets and behind bars, and to that end, as AG, we've arrested over 500 gun traffickers just in this community. We also have to recognize that these kids are suffering and they need our help. Gun violence, the opioid epidemic, two major public health crises. You know what else is? A lack of clean air and pure water in certain communities across our Commonwealth. You're here in Pennsylvania, where residents of our Commonwealth have a constitutional right to clean air and pure water. It's somewhat unique compared to other state constitutions. Article 1, Section 27 lays that out. Yet for too many families, they can't bathe their kids or drink the water that comes out of the tap in certain parts of Pennsylvania. Just last week, I was in Susquehanna County. It's up in the northeastern part of our state, right along the New York State border. I announced an historic criminal plea agreement with a fracking company that took responsibility for the first time for their crimes against our communities in polluting residents' water as a result of their fracking operations. As part of the settlement, the company will now pay residents' water bills for the next 75 years, but most importantly, they will be responsible for making sure that a new public water line with healthy, clean water is available to the community of Dimmock, which had their water mistreated by that fracking company. This new public water line was 14 years in the making, and we got it done. Because this public health crisis, a lack of clean air and clean water, that is also leading to a decline in life expectancy. And policymakers need to consider these challenges and these solutions in the context of the important work that you're doing day in and day out. Environmental issues, violence issues, drug addiction. These are all issues of public health that we need to work on. And so while it may feel like we're in a moment where we've been knocked back a bit, I certainly feel more hopeful and more inspired by the work that folks like you and others are doing than ever before, because I believe we will be able to meet this moment. And I want to thank you for the important work that you're doing to get us there. You know, as Pennsylvania's next governor, I want to invite you to join us to be part of these solutions. Mayor Bloomberg has invested a lot in the Commonwealth of Pennsylvania, and I hope you'll invest your time and your big brains in helping us do better here. And to me, if we're going to find one place to start when we want to improve public health outcomes, it has to start with our children and in our classrooms. Not only fully funding education, but also investing in school infrastructure so every student has a safe building to learn in. It means ensuring that every student has a great teacher and all the books and computers they need to learn, but it also means acknowledging the fact that there are students in those classrooms suffering and they need someone to talk to, which is why, as governor, I will put a mental health counselor in every single school building across Pennsylvania. And I invite you to be part of addressing our kids' mental health. A few years ago, we launched an initiative in the Attorney General's office called Safe to Say. This is an anonymous tip reporting system where we thought we would give kids an outlet to be able to give us a tip if someone was bringing a gun to school or someone was going to do something violent. Now, Lori and I are blessed with 4 kids, and our 4 kids looked at me when I told them about this idea. They said, "Dad, that is the stupidest idea ever." My kids don't think I'm particularly smart. And they said, "No kid is ever going to submit a tip." Well, I'm pleased to stand before you and tell you I'm not as stupid as my kids think, because we've received over 80,000 tips in just the last nearly 4 years. But here's the thing, what we were wrong about. The tips actually have not been about someone, thank God, bringing a gun to school or doing something violent against another student. We've had a few tips like that, but not many. In truth, of the 80,000 tips, 77% of them are about mental health, about suicide ideation, about self-harm, about students wanting to report not just themselves, but others who are crying out for help. We are the only place in the nation, the only state in the nation that has this data that's been gathered by the students. They're crying out for help. And if we really want to have good healthcare outcomes, then we must make sure that we are investing in the mental health of our children. They need our help, and we need to act now. I invite you to work with us on that. I also invite you to work with us on this public health epidemic that is gun violence. I'll do everything I can to make sure that we hire more police in our communities, that our prosecutors prosecute people who wreak havoc on our communities to the fullest extent of the law. But that's only one piece of it, the law enforcement piece. We must make sure that every leader stands up and does their part, from changing our laws to have universal background checks and to especially keep ghost guns out of the hands of criminals. That has quickly become the weapon of choice for criminals in our communities. But let's also work together to pass red flag laws in Pennsylvania, because I refuse to accept a reality in Pennsylvania where anyone has to fear in a classroom, a supermarket, or a club that people who shouldn't have guns can get their hands on them. We need good schools and safe communities, healthy students where everyone has the chance to be lifted up, where everyone has the chance to compete, where everyone has the chance to be a part of our collective success, where we invest in small business corridors so that those students, when they're walking on safe streets to and from a school where they can learn well, see those businesses as a place of opportunity for them, not just a place in a faraway distance that they can't achieve, but those local communities, those local businesses where they see a chance for them, where we can grow our economy, where we can have students in their schools see pathways to success and opportunity that's not just defined by whether you go to college or not, but where we put equal pride into a student who learns VOTEC and goes into one of the trades. Because we need welders as much as we need lawyers, and I would argue maybe we need more welders than lawyers, but we need to give our students an opportunity to succeed and see success in so many different ways, another way where we can find a positive and healthy outcome for our students by creating these new and different pathways to opportunity. So look, we have a lot of work to do. And I invite you to not just spend a few days here and go back to your communities and forget all about Philly, but I invite you to be a part of what we're building here in Philly and across Pennsylvania. I invite you to take advantage of the incredible generosity and opportunity that Mayor Bloomberg has created for all of us, not just by having a summit here, but by investing in our communities and investing in all of you and the groundbreaking work and research that you are doing. And I invite you to realize your role in our American story, in our American democracy, to think about our ancestors and their ancestors and the hard work they did time and time again when they were faced with challenges, to look our kids in the eye and say, we are going to do better for you. We're gonna leave this place better off for you than the way we found it. The work of writing this next chapter falls to each and every one of you. And I wanna say thank you for doing your part. Thank you for making a difference in your communities. Thank you for coming up with the big ideas of today and tomorrow that are gonna save lives. Whether it's lives that would be lost to an opioid overdose, lives that would be lost to gun violence, lives that would be lost because of unhealthy, unsafe environments where water can't be trusted to drink, you all are going to make a big difference in our communities. You all are going to help us write this next chapter of success and prosperity and good health in the United States of America. Thank you for being here. Thank you for your work. Appreciate you very, very much. Thank you. Thank you, Mayor Bloomberg. Thanks, everybody. Thank you.
My name is Malcolm Cunningham. I am the Health Outcomes Manager for ProMedica's eBuy Neighborhood Promise. The eBuy Neighborhood Promise is a place-based initiative in Toledo, Ohio that works to address the social determinants of health. Within my work, I essentially deploy dollars, work with partners, and develop and run a number of programs that address health and well-being. Our focuses include maternal and child health, chronic disease, food security, and violence. So one example of the work that we do is a project that we've been working on in partnership with Boston University's RISE Lab, the Lucas County Land Bank, the Mayor's Initiative to Reduce Gun Violence, and several other grassroots organizations. With this project, we pair satellite imagery with shootings, with census data and other indicators in order to understand which areas are most at risk in a really granular way. From there, simple efforts such as blight reduction, improving the quality of homes, greening, beautification can reduce the risk of violence and actual violence without it being displaced elsewhere. So while still relatively early in the Bloomberg Fellowship, the depth of knowledge, the perspectives of practitioners, of students, of professors from across the country has just been stunning and quite helpful. I'm looking forward to continuing to deepen my knowledge, my understanding of public health, and applying it in the context of Toledo.
Good morning. My name is Janel Cubbage, and I'm a Bloomberg Fellow working in violence prevention. In my role at the Johns Hopkins Center for Gun Violence Solutions, I lead suicide prevention, impacted community engagement, and racial equity initiatives. I'm looking forward to the upcoming panel because evidence-based policy is part of a comprehensive approach to gun violence prevention. Please welcome Senior Advisor for Implementation at Everytown for Gun Safety, Ruhi Bengali, Co-Director at Johns Hopkins Center for Gun Violence Solutions, Josh Horwitz, and your moderator, Managing Director of The Trace, James Burnett.
Thank you, Janelle. Thank you, Josh and Ruhi, for the insights you're about to share. Look, any conversation about gun violence, it has to acknowledge the lives lost. But it's equally important to acknowledge the progress that is being made, because that's how we understand this issue, not as intractable, right, but as something we can solve together. Josh and Ruhi are going to share what's giving them hope, what they see as some of the unfinished business for the public health model for violence prevention. We're also going to take your questions at the end, so please get those ready. Let's dive in. Josh, One of the bright spots in violence prevention has been something called extreme risk protection orders. Bring us all up to speed on what those are, how they work, and importantly, what do we know about their effectiveness?
Thanks. Extreme risk protection orders are state laws that create a civil legal process that law enforcement and in some states, family members and increasingly medical providers can ask a court to remove a firearm from someone who's at risk to self or others. They're modeled on domestic violence protection orders, so similar to those, it's a civil process, except these are focused on firearms, the removal of the most lethal means. So far, the evidence has shown that when it comes to harm to self, we're starting to get a body of evidence where the arrows are pointing that this is actually an effective strategy. Now, let me say, these are all these laws are new, so we're really starting to collect the evidence. And then when harm to others, interpersonal violence, the research is really early. But there's definitely some qualitative research that shows that some of these cases have been used to remove firearms from people intent on mass shootings like school shootings. So I'm very hopeful for these. They're in the infancy, and we need to go beyond the 19 states in the District of Columbia that have them and implement them in many states, more states across the country.
Let's talk a little bit more about the implementation. Ruhi, in some jurisdictions, we're seeing that it's law enforcement and city attorneys who are the most avid users of ERPOs. What needs to happen to ensure that these policies are used as a public health tool and embraced by clinicians and community members?
As Josh mentioned, extreme risk protection orders, or ERPOs, are an effective gun violence prevention tool that have gotten a lot of positive attention the past few years. And we need to look further to see where they're being implemented and how. And the data that we've collected shows that there's wide variation across states as well as within states. So Maryland, Florida have the highest per capita rates of ERPO usage, whereas Hawaii, Nevada, New Mexico have really low rates. And what we're finding is that having champions on the ground and having a robust infrastructure for ERPO implementation really matters. In jurisdictions such as King County, Washington, San Diego, California, they had committed stakeholders on the ground who invested in processes and protocols and ensured effective implementation of this tool, which is now, we're seeing that in the numbers. And I say that because at the heart of it, however effective the tool may be, it's not going to implement itself. We need to be investing resources, and so if we want to increase usage across the board, but particularly amongst clinicians as well as the community members, first and foremost, we need to raise awareness. Most practitioners and people just are not aware of the very existence of the tool. Secondly, we need to invest in training resources and modules so that these stakeholders understand when is it appropriate to use an ERPO, what are the steps that they would need to take within a particular state in order to get one, and so on and so forth. And then lastly, because there are so many stakeholders involved at various stages of the ERPO process, there needs to be better communication and collaboration across all of those levels.
So we have ERPOs, we have the Bipartisan Safer Communities Act, we have too many new funding streams, or at least available funding pools for public health interventions, street outreach, the whole list, more than we can get into here. Think ahead for us 5-10 years. What's it going to take? The one thing you think is necessary to make sure that we don't squander this moment, the momentum that the field has?
I think, first of all, you have to take these resources and lean into them. We need champions in every state who are going to say, I will get those grants, I will learn about the Burn JAG program, and I will be the champion for this state. So it's understanding the federal streams of money, having, as Ruhi said, taking a champion who can lean into these things, and then all of us to say, we want to implement this. You mentioned hope at the beginning. I have lots of hope, but hope's not a strategy. Y'all need a strategy. We all need a strategy for implementation, and we're working hard on that.
Ruhi?
As Josh said, implementation is the name of the game. We already went over some of the steps of that. I think in addition to that, those who are most impacted by gun violence need to be part of the solutions. There are racial disparities across the impacts of gun violence, and those communities need to be in the room when we're making decisions on what the solutions need to be for those communities. I think that includes using this funding, these resources, to expand our focus, not just on the implementation of the policies, which is extremely critical, but also to focus on underlying factors of gun violence, such as focusing on investments in housing, employment, mental health resources, healthcare access, the list goes on. It is truly a public health approach to gun violence.
So let's now take some questions from the audience. I think we have time for one, maybe two, maybe three if we talk fast. Who's got a question for Josh or Ruhi? Raise your hand. We've got mic runners. I see one here in the front.
Are you including emergency departments in the education about this and maybe integrating this into order sets, for example, in emergency medical and in electronic medical systems?
So Shannon Frateroli, who couldn't be here today, but is leading that effort and trying to create healthcare navigators so that we're piloting some efforts within Baltimore to look at exactly those issues, how to make this easy for clinicians to do this. Yeah.
Thank you. There's a hand up in the back.
Hi, thank you for this important conversation. My question is about the, do we know about how the ERPOs are actually being used?
We know a little bit. We need a lot more data, but I think what we're finding is that there is research and data to show that, in some states, a vast majority of them are being used in cases where someone is threatening self-harm, is at a risk of harming themselves. But there are increasing number of cases across all of the 19 states that are showing that these are cases where folks are threatening a specific individual or are even threatening sort of mass shootings or school shootings, and those early signs are being picked up and intervened on, and an ERPO is being issued.
We have time for one more.
Good morning. Thank you for a very informative session. I was wondering if you could share your thoughts on what are the most critical issues ahead for ERPO in the US?
I think you need to have more education. We need to ensure there's access for every community, and we need to make sure that we fully evaluate these laws and the data is available.
Thank you, Josh. Thank you, Ruhi.
Thank you.
Thank you.
Hi, I'm Matthew Chin, and I'm a Bloomberg Fellow alumni from 2019. As a Bloomberg Fellow, I worked in the adolescent health focus area with my partner organization, the Charles B. Wong Community Health Center, serving Asian American adolescents in New York City. Since completing the fellowship and my one-year service obligation, I've transitioned the skills I've gained to a new role at the Center for the Study of Asian American Health. My work currently centers on building and evaluating innovative food system programs to create more equitable programs for immigrant populations. At the Center for the Study of Asian American Health, a large part of my work focuses on social justice and advocating for populations whose needs are often overlooked. So I'm especially excited for this next discussion. Please welcome back Associate Director of the Bloomberg American Health Initiative, Michelle Spencer, and New York State Health Commissioner, Dr. Mary Bassett.
Well, thank you so much, Matt. And Dr. Bassett, thank you for joining us this afternoon, or this morning. We should jump right into these critically important questions. We're talking about advancing equity in public health. And so my first question for you is, how does addressing equity impact life expectancy? And what are the interventions and partnerships that public health should be exploring? We saw and we heard the data early this morning, and so please help us understand.
Sure. Thanks very much, Michelle. And I just want to say that this is an incredible gathering, and the best part for me is seeing so many young people. It's really a wonderful thing. So we've heard a lot of the data this morning, and I want to applaud the initiative and the Bloomberg Foundation for putting a spotlight on the reduction in life expectancy. Everyone should understand how shocking this is. This is something that should not happen during peacetime. And it's happening in our country, one of the wealthiest and most powerful in the world. And the loss of 3 years of life expectancy also reflects a much larger loss of life expectancy among marginalized groups that, because of bad policies and a tortured history, have been deprived of the resources for a healthy life. That means that there's been a bigger loss of life expectancy among Blacks and Latinos, and a bigger loss of life expectancy among people of the indigenous. That stands now at 65 years. The only other place in the Western Hemisphere with a lower life expectancy is Haiti, one of the poorest countries in the world. So when we talk about tackling life expectancy, we have to be talking about equity. And to me, what that means is never tick the box. Yeah. Never just say the words, but say, what does it mean to bring an equity lens to everything we do?
And how do we do that? How do we ensure that when we talk about equity, we're not doing it in silos, that in our research, in our advocacy work, in our education, in our curricula, in academia and government, that we're not just doing this through siloed lenses, but that we're actually thinking about equity in a critical way, and that it's inclusive?
So I wish that there was a really simple soundbite for the answer to this question, but I'm afraid that there's not. I mean, we have to break down our interventions into specific actions. And we have to go for things that are doable, and that's what is outlined here. Practical, sensible steps that can be taken to tackle the drivers of the reversal in life expectancy. But at the same time, we have to understand that all of these are interrelated, and that a racial equity lens is required in every single one of them. Can I give you an example?
Yeah, please.
All right, so I was thinking about this morning, and the terrible toll of gun violence in our nation, which often is experienced mainly as interpersonal gun violence. But we also have a terrible problem with police violence in this country. And we have to think about all of these as interrelated. I'm sad to say that despite the outpouring of alarm during, in the aftermath of the murder of George Floyd, that the number of deaths at the hands of police as a result of a police encounter has continued to rise in this country. And it continues to be overwhelmingly, people of color, a disproportionate share. So I think when we think about interpersonal violence, we also have to think about the other sources of violence in a community, and that includes thinking about the police. So that's what I mean, that it is a big challenge to bring an equity lens to the work that we do. It's true for everything. We heard about food systems, and I was really pleased to see that there's a fellow from Charles B. Wang. We worked with them, and I'm sure the City Health Department in New York still works with them. But many communities have really very difficult access to healthy foods. And so there are lots of things that we can do to make that better. But one thing that we should never do is to say that this is related to some kind of cultural defect of people of color. That's really important. We've heard a lot of really kind of gloomy statistics this morning, and people often ask me, how do we stay positive? And the answer is that this is not in our genes. Yeah. This is reversible. This is human-made. Yeah. And that's what makes me hopeful, but I'm really grateful to Mayor Bloomberg for pointing out that the obstacles often mean that we have to get out of our lane in public health and talk about the political barriers to taking the right actions for public health.
Can you talk a little bit more about that point, the political drivers, as well as the structural barriers to equity and to advancing equity? I know that we're almost out of time.
I know. I'm looking around to see if I can see the clock, and I think we have 10 seconds remaining. So that's the big picture. I was looking at a paper, and I'm going to run us a little over, that some of you may remember, some of the older people, was called The Actual Causes of Death. It was written by McGinnis and Faggy back in 1993. And it pointed out that it's not just diabetes, it's also unhealthy food, alcohol, all the things that tobacco. But we also have to look at the interests that keep these unhealthy exposures in our midst. And they're political, and they're corporate, and everybody has to exercise their right to vote.
Awesome.
I think I'll just stop there.
Thank you, Dr. Bassett.
Thank you, Michelle.
Thank you, Dr. Bassett. Thank you all.
All right.
Please welcome CEO of Bloomberg Philanthropies, Patty Harris.
Hello, everyone. I'm so glad to see everyone in person at the Bloomberg American Health Initiative Summit. And we're here today, obviously, because we recognize the gravity of the public health challenges before us. And while we've made progress, you've been listening, there still is so much more to be done. You know better than anybody else. As Bloomberg Fellows, we can't make more progress unless we work together and alongside strong partners. And that's why I am so pleased today to introduce a very special guest right now. She's one of Bloomberg Philanthropies' best partners in our work to curb opioid overdoses. And we're so pleased to have kicked off our partnership with her office about a year ago. But her leadership in public health doesn't stop there. Last year, she successfully repealed a New Mexico law that criminalized abortion. And she directed state funding to build an abortion clinic on the border of New Mexico and Texas after the Supreme Court overturned Roe v. Wade. And this will not only expand abortion access in her state, but to neighboring states as well where it is illegal. She's also worked to promote common sense gun safety reform, and she's a proven leader on fighting climate change. Thanks to her, New Mexico passed a climate bill to transition the state to 100% carbon-free electricity by 2045, which will improve public health and create jobs. We're grateful that the people of New Mexico just re-elected her to serve another term as governor, and very grateful to have her here today. We're really lucky that she came to this conference. So please join me in welcoming Governor Michelle Lujan Grisham.
Not going to let all those other governors be taller than me. Patty, thank you for that warm introduction. Thank you to everyone who's participating today. And frankly, as all of us know, thank you to Bloomberg Philanthropies and for the hosting of the American Health Summit. And I'm one of those states that is the beneficiary of not only the global work we are all engaged in, but this is where the rubber meets the road. We put people right into the public health offices to shore up any number of our efforts. And in our state, making sure that we're tackling substance abuse and we're dealing it from both a harm reduction standpoint and a prevention aspect is critical to the well-being, certainly of our families in New Mexico. So a big shout out to Bloomberg. Thank you all so very much. And thanks for having me. I got into public health literally by accident, unlike most of you here today. I was working on supporting older folks and their families, and the truth is, everything is public health. every single aspect. If we're going to talk about fulfilling our goals to make sure that people are healthy and happy and are successful and are reaching every single opportunity that we are identifying, then it is all public health. And I know that you're going to talk a lot about all the different social determinants. We just saw a panel on equity. All of these aspects are critical. But I want to take the giant step forward, and to some degree, for many of us, backwards. It's poverty. And I'm leading a state that, when I was elected, was the most impoverished state in the nation. I'm proud to tell you that we've moved out of poverty by 3 points, and that's exactly what we need to be doing. And now we're third in the country, and I intend for New Mexico to lead the United States in eradicating poverty, because when we eradicate poverty, every single issue that we're talking about here today gets addressed. Every single one. And while I don't want to be critical or negative, the reality is we're nibbling around the edges. Now, I represent a beautiful state, and my family's been there for literally hundreds of years. And many other New Mexicans have been there from time immemorial, thousands and thousands of years. And institutional, generational poverty has literally plagued our state for as long as, frankly, anyone here or anyone in New Mexico can remember. So we're tackling it from every aspect. So number one, we need progressive tax policy that lifts up working families in very meaningful ways, and they have to be sustained. So we have done that. We were the only state that was able to continue the child tax credit, which I will tell you has lifted, right? We're beating the averages, and while on average now the country's sort of losing ground, because that's not a sustainable tax credit, because it was only temporary at the federal level, New Mexico's the only state moving in the right direction, working every minute of every day to eradicate child poverty. We are also, right, we doubled the working families tax credit. We're increasing earned family income tax credits. We're making sure that we're reducing or eliminating taxes on retiree benefits, and in a state where grandparents are raising grandchildren at higher than the national averages, Social Security and military incomes cannot be taxed in our state. It's about making sure that we have enough money in the pockets of every single family. We are spending hundreds of millions on affordable housing and making sure that rental assistance doesn't become a one-off. It becomes a sustainable, regular practice, making sure that our working families have everything they need to be successful. Two, make sure that you're dealing with your families early in the system, as early as possible. So I want to talk about our educational reforms, because they are, frankly, magnificent. And we are leading the country. And I want everyone else to follow our lead, because it will make the differences so that you eliminate in one generation all of these issues related to poverty. All right? So look, we have the most, I'm going to go at the far end. We have 45,000, so in a state with only 2 million people, that is a remarkable number of folks going back to college. We have free college, full-time, part-time, 2-year, 4-year, trades, certificates, licenses, anywhere, anytime. All of the other private sector money pays for living costs and all of the other aspects that really hamper anyone's ability to afford college in today's climate. We saw 4,000 additional New Mexicans go to college this last year. We're second in the country for enrollment. And while most of the country, as you know, is seeing a drop in enrollment, we saw the highest college enrollment in over a decade in the state of New Mexico. And we're going to keep that going. We called it a moonshot, $1.5 billion invested into public school, and I'm going to tell you that we now have the highest paid public education educators in the West. And we're going to have the highest paid educators, if I have anything to do with it, in America. And we're asking the legislature to underwrite their health care costs and starting by eliminating their health insurance premiums and having that be the responsibility of the state of New Mexico. We want them to stay. We want them to have healthy families. And when we ask the most critical folks to do this work, by golly, we shouldn't be impoverishing them and their families. All right, we're doing extended learning in the classroom. We're doing a thing called the Family Income Index, which is more money for individuals and kiddos in the classroom. We now have universal pre-K, so every 4-year-old is in, and we are this close to every 3-year-old in the state of New Mexico. We are now the only state that's got a constitutional right to pre-K, and quite frankly, that right now, Congress is going to ratify that decision, I believe, on December 12th. We're going to be the only state in America that makes child care a constitutional right in the state of New Mexico. Most New Mexico families already qualify for free child care, not reduced, free. And I want every family in New Mexico to have free child care. We've expanded maternal health. We've expanded Medicaid coverage for mothers and babies, and the federal government should do the same. We've expanded infant mental health. We're expanding home visiting. We're expanding all of the things that mean that in that one generation, we are addressing every single issue that creates the negative outcomes, and requires all of us to be continuing our incredible studies on social determinants of health and equity. And the last thing, and I'm way over time, you gotta address the environment, and absolutely we are. We have leading methane and ozone rules. We're making sure that not only are we preventing all of our fossil fuel folks from putting any of our greenhouse gases into the atmosphere, we're working on strategies that pull carbon right out of the atmosphere. And as you all know, the federal government adopted New Mexico's rules, for clean air standards and methane pollution. If we do all of those things, clearly eradicating poverty, we will, in fact, in this country, lead the world in making sure that public health is the #1 issue, making a difference, seizing every opportunity. And before I go, I'm going to get the hook, I'm telling you, we have one more incredible announcement. In New Mexico, starting right now, no one pays for a meal in school. And we are leading the nation in addressing food insecurity in the country. And that's how you do it. And this doesn't mean just pizza slices and chocolate pudding for all my nutritional experts right here. This means farm-to-table, fresh food, scratch cooking, and incentivizing it in our schools. So I want to leave you with this. Every single good idea comes from this group right here today. You're making a difference for so many families, and really my job here today, in addition to going way over my time allotted, I'll never get invited back, was to tell you that this is the work that you do, that these policies are evidence-based, that they make a real difference, that you find the path and lead the way for states like mine to enact these policies and these investments and the families who depend on us. And it is my chance today to thank you from the bottom of my heart for making a difference for every New Mexico family, every child, every person who needs every aspect of our investment and intervention. You make a difference for everyone. You're leading the country, and I thank you. Thank you.
Please welcome Public Health Program Lead at Bloomberg Philanthropies, Dr. Kelly Henning.
Good morning. It's great to be here with all of you today in person. Governor Grisham's words were incredibly inspiring. Thank you, Governor, for being here with us today and for being such a great partner of ours in the overdose work. And now I'd like to introduce another great partner. Dean MacKenzie was appointed the 11th Dean of the Bloomberg School of Public Health in October 2017. And as COVID unfolded, she led during a time of great challenges and opportunities for the school. She has served the school as director of the Johns Hopkins Center for Injury Research and Policy, senior associate dean for academic affairs, and chair of health policy and management. Most recently, she served as the Commonwealth Fund Commission on a National Public Health System. This critical commission seeks to articulate a vision for how U.S. federal authority, resources, and leadership can join to create a national public health infrastructure that improves health and equity and enhances the country's preparedness for future crises. But most importantly, I'm lucky to consider her a friend. So please join me in giving her a warm welcome to our stage, Dean Ellen MacKenzie.
Well, good morning, everybody. It's great to see you here. We had a great time last night, and it's just really wonderful to see you here today. Thank you to Kelly for that warm introduction, and of course to the Bloomberg Philanthropies for their support and commitment to our university and to our school. All in all, I think you'd agree with me that this has already been an amazing morning. It is not every day we get the chance to hear from so many exceptional public health leaders. Thank you to our fellows, our graduates, our faculty, President Ron Daniels, and of course, Mayor Bloomberg, who brought us all here together. Thank you. Now, for the next part of the program, we are excited to share a video that celebrates the 88 Bloomberg Fellows who have already graduated from the program. This growing network of scholars, educators, practitioners are devoted to making our country healthier, safer, and more equitable. They are conducting their work in our cities, our suburbs, and in the rural corners of America. It's always inspiring to hear from our fellows after they graduate because they make clear the power of this initiative. We see what happens when people who are deeply committed to their communities are given the chance to gain knowledge, skills, and connections and take their impact to the next level. These graduates are helping teenagers connect to work, school, and family. They are combating the overdose epidemic with great empathy and innovation. They are safeguarding our environment, improving our food systems, and finding new ways to prevent violence. They are certainly showing us the meaning of our theme, public health on location. I'm very pleased to introduce a video that spotlights our graduates. And for those of you who are just entering the program, please take notice. And this should give you the excitement and the commitment to continue to do all the great work you are doing in the program. So let's take a look at the video.
Up in the morning and out to school. The teacher is teaching the golden rule. American history and practical math. You study them hard and hoping to pass. With the one you love, you're making romance. All day long you've been wanting to dance. Feeling the music from head to toe. Round and round and round you go.
name is Krister Monahan, and I'm the Chief Program Officer for Rebel Recovery, located in Palm Beach County, Florida. We are a grassroots, peer-led recovery community organization guided by harm reduction principles, and we seek to improve the health of people who use drugs or are impacted by substance use. Our approach is to meet people where they're at and celebrate any positive change. We are one of the few hybrid recovery community organizations in the United States because we offer syringe and harm reduction services alongside peer recovery support programs. Our mobile syringe and health services program serves as a point of entry for many to engage in a range of services, and our peer support is about building connections through shared lived experience. We support any path by any means, and this becomes the bridge between chaotic use and stable living for many we serve. As a person in recovery, I understand this journey looks different for everyone. I know what it took for me to get where I am today, and now I use my experience to support positive change in others' lives. The addiction and overdose crisis is complex and must include community-driven, multifaceted solutions. The Bloomberg School of Public Health has propelled my work in this area as a public health professional and supported the growth and impact of my organization.
Hi, I'm Fola Akinnibi. I'm a reporter with Bloomberg News, and I'm here with Jacqueline Romero. She's the U.S. Attorney for the Eastern District of Pennsylvania. She's been in that role since June of this past year, though she's no stranger to the office. She worked as an assistant AUSA in that office for about 16 years. So thanks for joining us, Jacqueline.
Thank you, Fola.
We'll get started. So life-saving treatments like methadone and buprenorphine can really help people who have opioid use disorder, but there are barriers to that care, and I was hoping you could talk a bit about some of those barriers and what your office and the Department of Justice more broadly is doing to ensure people have access to care.
Sure. Well, the Department of Justice takes a three-pronged approach to the opioid crisis. The first part of what we do is education and outreach, going out in the community and talking to individuals about the real risks. We work with our partners like DEA, on their One Pill Can Kill campaign. And the second part of what we do is what people mostly know is our enforcement. And we go after the drug traffickers and people bringing the drugs into this country. The third part is what you're referring to is the recovery part, where people are legitimately being prescribed medications for opioid use disorder and are on their avenue toward recovery and care. And the Americans with Disabilities Act defines opioid use disorder as a disability. And so there are protections that we're able to enforce as the department to help those folks. There's a stigma around treatment. If you're on methadone and Suboxone or these other drugs, a lot of employers and other groups may discriminate against you. And so we can use the American with Disabilities Act as a tool to assist people in recovery.
So it sounds like you guys see this as a civil rights issue, and I was hoping you could talk a bit about the sorts of areas that you guys are using this sort of legal argument and the types of cases that you guys have brought as well.
Yeah, well, if you look at the Americans with Disabilities Act, there are three titles that we primarily enforce, Title 1, 2, and 3. Title 1 covers areas of employment. So if an employer discriminates against someone who is on legitimately prescribed medicine for their opioid use disorder, both EEOC and the Department of Justice can get involved. The second title is state and local governments. So the typical cases that we see there are sometimes in prisons and access to medically assisted treatment in prisons, in things like probation departments. Sometimes they have hard and fast rules saying you can't use medicine to treat your opioid use disorder. You have to be completely drug-free. And then Title III of the ADA covers goods and services, essentially, places of public access. And so when you think of, again, employers that discriminate might fall under Title III and other types of goods and services. So those are typical kinds of cases we would bring.
And do you see other areas where the DOJ can help and perhaps step in to help ensure that people are able to get the care that they need?
We've brought many unique types of cases. So in medical settings, sometimes nursing homes, for instance, might have a blanket policy. We don't accept people who are on medicine for treatment of their addiction. That's an area that we've stepped in before. Sometimes zoning laws, believe it or not, if there's a treatment facility that wants to be located in a particular neighborhood and the town is treating them different than they are treating other similar facilities, we might get involved because that's discrimination. So it can be a lot of unique scenarios where the Department of Justice steps in to really get rid of those discriminatory barriers to recovery. That's the ultimate goal at the end of the day, is to remove that stigma and remove the discrimination so that people can get on the road to recovery a lot faster.
And correct me if I'm wrong here, but it seemed like in some of the cases that I've seen that you guys have taken on, it looks like you guys want to ensure that people who are already in care or people who are already using these medicines can continue to access them in the setting they need, and they're not discriminated against. But I was wondering if you felt like there was room for you guys to ensure that people who may need in the future, or that they would have the option for care going forward.
Yeah, that's really up to doctors, and that's beyond my expertise because now you're getting into standard of care. For instance, in the prisons, if someone is on medicine for their addiction, when they walk in the prison door, we have to ensure that they continue to have that treatment while they're in prison because they were previously on it. Just like we would have someone who's on, let's say, epilepsy medicine, they continue their treatment while they're in prison. But to say that someone who comes into prison who's using drugs illegally should then get put on medically necessary treatment is a standard of care issue. And that's really up to doctors and experts in the medical field to talk about standard of care and what should be the standard of care. That's not up to the Department of Justice.
It looks like that's all the time we have, so thank you so much for taking the time.
Thank you for having me.
Good morning. My name is Jason Piotrowski, and I'm a Bloomberg Fellow studying addiction and overdose. I work just over the Delaware River in New Jersey, and I'm currently a captain in the New Jersey State Police. For more than 9 years, it's been my job to work on the overdose epidemic. During 2013, we created the Drug Monitoring Initiative, which provides complete surveillance of all naloxone administrations by first responders in the state of New Jersey and all drug seizures reported to forensic labs in the state of New Jersey. We use this data to identify trends, patterns, and emerging threats in the drug environment, but more importantly, we use the data to support the people, the families, and the communities that are most affected by substance use disorder. Earlier this year, we received a federal grant that's going to allow us to hire 8 recovery coaches and 2 supervisors, and they're going to help the New Jersey State Police to further reduce community drug harms. As we all know, this epidemic, there's been not a lot of great news, but I'm actually very happy to give some today. Through our partnerships with public health and treatment, prevention, community leaders, harm reduction professionals, while 1 overdose is still too many, this year, year to date in New Jersey, we're down more than 10% in overdoses. It's now my pleasure to please welcome, to introduce the next panel. Please welcome Commissioner of New York State Office of Addiction Services and Support, Dr. Janel Cunningham, Professor of Epidemiology at Brown University School of Public Health, Dr. Brandon Marshall, Senior Director of Programs at On Point, New York City, Kaylin C., and your moderator, staff reporter at the Philadelphia Inquirer, Aubrey Whelan.
Thank you so much for that introduction, Jason. I'm really excited to be here. Let's get to it. So yeah, New York City opened the first supervised injection site just about a year ago. Kaylin, I'm hoping you can tell us a bit about how it works and what sort of challenges and non-challenges you faced in opening it. What was easy, what was hard?
Yes, so I'll rapid fire this because we don't have a lot of time, but November 30th, 2021, the first 2 safe consumption sites in the United States were open, y'all. Let's have it. Yes, they exist. They are safe spaces where people who use drugs can bring illicit materials and use them safely under the supervision of a trained staff. The sites have been used over 50,000 times. They've intervened in 633 overdoses in their first year, calling the ambulance only 10 times. And we have, thank you, yeah, let's clap for that. Quickly, yes, we have no time. And we have 2,200 registered participants at the sites.
Awesome. And what is the funding model for the site? How do you guys work?
Yeah, that's the tricky bit, thank you. So because we don't have federal permission or state permission officially to operate the sites, funding is the big question. So no public dollars can be used to operate the sites. And for any jurisdiction that's thinking of opening their sites, and I know that Philadelphia is, and we're with you all the way in that effort, really securing sustainable funding for this evidence-based public health initiative is going to be key to scaling up this life-saving intervention across the country. So we're really optimistic that the opioid settlement fund money can be used, and we really are calling on jurisdictions to advocate hard for those public dollars to go to operating these sites. For now, it's foundation and discretionary money and donations, so it's a tough position to be in.
Dr. Marshall, you are in Rhode Island, which is also approved sites, but hasn't opened them yet, and it went the legislative route. Can you talk about that? And I'd love to hear from you as well, Dr. Cunningham, about kind of how in New York you guys are working at a state level, because I know that the OPSs are operating at a city level in New York City.
Sure. So we were the first state in Rhode Island to authorize overdose prevention centers through legislation, which passed, I might add, with broad bipartisan support. And we also recently are now, as a state, financially supporting organizations that wish to open an overdose prevention center using our opioid settlement dollars, which is allowable under that agreement. So I think what this shows to me, right, is that harm reduction is achievable, and the broad public and political support for harm reduction can happen. And I think Rhode Island shows that. You know, that's really it. Until we think about harm reduction as a key component in a continuum of services for people who use drugs, we're not going to see the end of this crisis. That's simply it. And so we're leading the way, and I do hope that many other states and jurisdictions follow us.
I would absolutely agree about really thinking about harm reduction and embracing it in terms of all of the strategies that we use across the state. And this is something we're doing in New York. So I've been the commissioner for a year, and really my leading priorities are harm reduction, a data-driven approach, and using an equity lens in everything we do. And in terms of the kinds of harm reduction policies and activities that we're supporting, including really expanding harm reduction supplies, so naloxone, fentanyl test strips, and supporting syringe services programs, bringing services out to where people are, so really going out into the community, bringing methadone out into the community through mobile units, doing outreach on the streets, on the corners, under the bridges, linking people to care. And so really thinking about harm reduction as a full continuum to reach as many people as possible and those who are at the highest risk.
Yeah, I'm curious if any of you can talk a bit about community outreach, both to, and I hate to draw the distinction between, the community of people who don't use drugs and the community of people who do this. They're all one community, as we all know. How do you do outreach to people who requires harm reduction services, and also people who are living near, the places where these harm reduction services are distributed, and kind of how do you get people on board or, get them acclimated to the idea that, say, there's going to be an overdose prevention site next door?
I think it's important to remember that we open and operate programs for 2 different stakeholder groups. One, the people who are going to use the programs, but we also open them to address the needs of the people who live in the neighborhoods where these programs are going to be sited. So for us, it was really about acknowledging that there were no American examples to point to, and that we needed to be fully transparent and patient with the communities where our sites were operating, and allow that conversation and allow those deeply held feelings that people have about drugs, drug use, and people who use drugs to come up and not shy away from that conversation. So from our perspective, we opened our doors. We've been open for just over a year, and we've hosted over 400 tours, and we felt that we had a responsibility to do that. So our public engagement strategy was a little bit more after the fact. Sometimes it's easier to ask for forgiveness than permission, especially when you're going to be opening the first 2 safe consumption sites in the United States. But that has really been a winning strategy. When people come and see the sites and how they operate, they understand that we're trying to meet the needs of 2 stakeholder groups, that it is evidence-based, and it is solid public health strategy, and that's won the day for us.
I would also just add to that in terms of who should be doing outreach, what that should look like. It should be everywhere, right? So it should be community-based organizations doing outreach in their community. It should be prevention, treatment, and recovery providers as well. I mean, we have to do things differently. We are at the worst overdose crisis ever in our country's history. And so we have to get outside of the walls of the traditional way in which we've been providing care, and we have to go into the communities. And so supporting all of the service providers is really critical.
I know that obviously, yesterday there was a deadline in the case here in Pennsylvania or in Philadelphia to open a supervised injection site that the federal government has asked for another extension on. I'm curious as to, what either any of you think on, sort of efforts around the country outside of your own jurisdictions to open these sites and how it compares to what you did.
Yeah, these delays are harmful, right? Every overdose death is preventable. And these sites can save lives. They start saving lives the days with which, after which they open. And so these delays are harmful. I think we need to move towards implementation in jurisdictions as rapidly as feasible, and a stronger indication from the federal government that this is an evidence-based intervention that can and should be rolled out in communities that are highly impacted by the overdose crisis would go a long way, I think, to seeing these interventions open and foster and thrive in communities across the US.
Where is Rhode Island in the process right now?
So we are financially supporting these sites as a state through our settlement dollars. That RFP went out and organizations have applied, and we're expecting that funding to be released early in 2023. The legislative and regulatory process we took is slow, and I won't be happy until a site is physically stood up and open. But what we've seen is broad support politically, publicly, through that process. So I'm hopeful that we're building a strong foundation from which to continue to grow and see support for harm reduction more broadly, not just overdose prevention centers.
Can I add one tiny thing to that? One thing that I think is evident is post-opening the sites, and because of what's happening in Rhode Island with the legislation, is the harm reduction community nationally is working together in a very different way around the launching of the sites. And each jurisdiction will find its own path, whether it's declaring a public health emergency or going the sort of very rapid surprise, non-regulated route that New York went, or the legislative route that Rhode Island went. But the harm reduction community and government stakeholders across the country are interested in opening these initiatives and really proactively taking steps.
Dr. Cunningham, in states that are, like Pennsylvania, where we have, kind of more radical interventions trying to get implemented in some of the larger cities, but, there's not statewide syringe access, for example. What can places, with very different pictures of the opioid crisis, what can states do to kind of address, the different access issues across a very broad spectrum of people?
Yeah, so certainly in New York, we have a very large state, and we have all the way from New York City to the North Country, which is the area that borders Canada, and they're obviously very, very different communities. And so I think what's really important is to understand what the challenges are in each of the communities, and then think about the potential solutions, which are going to be different. And then I think the other thing is just really learning from each other. I hear sometimes, what happens in New York City can't happen in these other places, and that may be true, but I think we can sort of tweak, we can learn, and we can tweak our approaches accordingly. So I think that is the job of government, to really think about the specific differences and challenges and then meet those challenges.
Great. Thank you, guys. This is just about time. It's been a wonderful discussion, and you were all very quick, so I appreciate that. Thank you so much. And this concludes the program's focus on addiction and overdose. We'll now move on to adolescent health, investing in opportunity youth. And let's go on location 86 miles from here to Maplewood, New Jersey. Thanks, guys.
My name is Emily Witkowski, and I am the teen librarian at the Maplewood Memorial Library in Maplewood, New Jersey. Our library's mission is to connect people to information, ideas, culture, and each other. We do programs, we have conversations on tough topics, we partner with our community, and it's all in an effort to connect each other. There are really no other community organizations that are open to all the way the public library is. We help people find housing, we help people apply for health care, for jobs, and for teens in particular, we provide a safe space for them to learn and grow and become productive community members. I think being a Bloomberg Fellow has enhanced my work at the library tremendously. For example, when the high school community experienced a tragic loss, I was able to provide social and emotional learning resources to the administrators and counselors at the school, and I found those resources through my coursework and research at Hopkins.
Please welcome Health Commissioner of the Philadelphia Department of Public Health and a true friend of the initiative, Dr. Cheryl Bettigal.
Good morning, everyone. Ooh, I'm sorry. It is such a pleasure to be here with you all and really a privilege. And I want to start this morning with a few thank yous, one of which is a long-delayed one, to the Johns Hopkins Bloomberg School of Public Health, I can't talk this morning, where I did my MPH years ago and where I learned things that I still use every day here in Philadelphia. Also, to the Bloomberg Fellowship and to Mike Bloomberg for just a tremendous opportunity that we have taken really full advantage of, and just tremendous thanks. We are, I believe this year we have our 7th fellow starting, and it's just an unparalleled opportunity for learning, for professional development, and for investing in the future of public health leadership in Philadelphia. So thank you. And I also, as I'm thinking about the work we do here in Philly, wanted to thank our thought partners, the Partnership for Healthy Cities, Big Cities Health Coalition, the people we learn with and grow with and try to solve these really difficult public health problems with. And then, of course, all of our community partners without whom we really could not do this work. So I get to talk with you this morning about adolescent health. And it's an amazing age and an amazing moment of possibility. It's a moment for us in public health where we know that if we could change the systemic factors that cause disparities, we could change the whole course of a child's life. It's also a moment when we, as a society, as healthcare providers, sometimes even as public health professionals, sometimes switch from treating children, especially young children, as the vulnerable beings they are, who need support, who need nurturing, and for whom we really recognize the importance of systemic and environmental impacts of racism and injustice, to a framework in which too often we tend to see teens as individual actors and too often as individual bad actors who are responsible for their own problems through bad decisions. And I know most of us in this room try our best not to do that, but I also know that we tend to frame things in terms of behavior change sometimes, and we can find ourselves slipping into that individual actor framework. And so as I'm talking through this, I want all of us to be thinking about where are the opportunities to dig deeper and to look for those systemic causes, because as we all know, willpower does not differ by neighborhood, and the urge to pick up a gun to defend yourself has to do with everything around that teen and not the teen themselves. So how are teens doing in Philadelphia? Well, the next part of this will be a little grim, but our toughest problems, as you know, are gun violence and drug overdose. And you've heard some about those. You will hear more today. But for teens in Philadelphia, we have had 174 teens shot in 2021. Final data isn't in yet on 2022. We had 34 deaths. So, and you heard from Josh Shapiro very eloquently about the impact on all of the other teens who are watching as this happens in their neighborhoods and to their friends and to their relatives and who have lost family members and big brothers and fathers. And so it is devastating. Drug overdose, similarly, we are more than 1,200 a year. So many families touched in our city. There are also major risks to the ability of our teens to thrive. And those include poverty, and we are the poorest big city in America, chronic unemployment, which is very closely tied to violence, the exposure to violence. We've talked about lead poisoning, and we will be putting out data sometime in the next few weeks showing a very close link between elevated lead levels and both violence, victimhood, and perpetration, which is true at every level of income. Our underfunded schools, a crisis in affordable housing and poor housing quality, which when coupled with high tobacco use rates, leads to really, really high rates of asthma. More than 20% of our kids have asthma in Philadelphia. It's the #1 cause of missed days of school. And if you think about the impact of a child who is already struggling with multiple strikes against them, missing 15, 20 days of school in a year has a huge adverse impact. And then, as you're going to hear more in the next panel, a teen mental health crisis, which is worsened by the fact that we don't have enough resources to help kids. But I do want to focus a little bit today on what's going right. And there is actually a lot going right in Philadelphia, including for teens. Starting with PHL Pre-K, which is free, high-quality pre-K for 3- and 4-year-olds. It is entirely funded by the Philadelphia beverage tax, otherwise known as the soda tax. It started in 2017, and all you need to qualify is to live in Philadelphia. So it's a game changer. Yes, this is amazing. The Octavius Catto Scholarship to Community College, which is a last dollar scholarship, including counseling, including food and transportation, to make sure that kids who can get themselves to community college can stay there. Programs like Youth Build, which help connect opportunity youth, teens who are disconnected from school and from work, into a program that can get them a living wage job. What I believe is the first in the country hospital-based violence intervention program collaborative between all of our hospitals coming together to share data. I'm running out of time, so I'm just going to highlight a couple more things. Opioid-only deaths in Philadelphia are declining. We have our overdose deaths overall are not because we have stimulant-involved overdoses, and we are working hard to figure out strategies that work. That is, I think, a different phenomenon, and we need to address it differently. Our tobacco policies are bearing fruit. Smoking rates are down from 25% to 15%, and they're under 2% for teens. And it's now required, if you're going to get an apartment rental license in Philadelphia, that you have a lead-free or lead-safe certification, and 95% of rentals are now certified. So I'm going to stop there. Lots more to do. And, I'm just so excited to be part of this work with you and grateful for the learning we have from all of you. Thank you.
Please welcome Bloomberg Assistant Professor of American Health, Department of Health, Behavior, and Society at Johns Hopkins Bloomberg School of Public Health, Dr. Kiara Alvarez, Professor in Johns Hopkins School of Public Health, Medicine and Education, Dr. Holly Wilcox, and your moderator, Bloomberg Fellow and Public Health Reporter at Kaiser Health News, Aneri Patani.
Thank you, Holly and Kiara, for joining us today to talk about this important topic. Over the past few decades, we've seen an increase in thoughts of suicide, suicide attempts, and unfortunately suicide deaths among many youth of color, including Latinx youth. Kiara, could you talk to us a little bit about what are the concerning trends that we're seeing and what are some of the factors that might be behind them?
Absolutely. So one of the challenges that we see is that we have this idea that suicide risk peaks in middle age. We've heard that statistic. But when we actually look at subgroup differences for people of color, the risk actually peaks in adolescence and in young adulthood. And so it's a different pattern that really speaks to the need for early intervention. And at the same time, we see these massive disparities in the kinds of mental health care that youth of color are getting. And so including for Latinx youth, we see the lack of access to preventative care and to mental health care when there is suicidal ideation and behavior. But we do see that there's a greater likelihood of then receiving services through emergency departments or of being funneled into punitive systems, school behavior concerns, as well as the juvenile justice system. And so without addressing those inequities and understanding what the underlying factors are, it limits our ability to engage in effective prevention. And for Latinx youth specifically, there are barriers for particular groups, including language access, low rates of insurance in many states, and the lack of culturally competent care available to families.
Yeah, I really appreciate you, comparing when we have different risks, different populations, there's different risk factors, and therefore our policies have to address different issues as well. So Holly, I'm hoping you can talk to us a little bit about, there are, policies that are being tried at state and national levels to address this issue. What are some recently passed ones that are trying to address youth mental health and suicide prevention, and how do you think they might affect Latinx youth especially?
Sure, I'm going to focus on some policies that are in the public health realm. And one of the barriers that we face in the field of suicide prevention is getting evidence-based practices out to those who need them, when or before they need them. And so there's a great policy that, or law that was passed in California. It's Senate Bill 224. In California, about 40% of the state is Hispanic. And so it will benefit lots of youth. And the idea is that mental health education will be embedded within health education for students in grades 1 through 12. So students will get developmentally timed mental health education in elementary school, then in middle school, and then again in high school. And they'll receive it by trained, highly qualified implementers or instructors who will deliver the training. And the whole idea, another idea behind this training is it will be given directly to students, but also that that it will be appropriate for a diverse student population, diverse by gender, diverse by race and ethnicity, by gender and sexual minority status, students with disabilities, and English language learners, which are, those students are often excluded from our traditional suicide prevention interventions because of difficulties schools have with having a Spanish-speaking implementer and pulling students out and so forth. And so I'm excited about this momentum that we have, a silver lining in the pandemic. Another is the Stand Up Act, which is a national law. President Biden signed it in March of this year, and it is a suicide-specific policy that will enhance the ability to bring awareness and prevention to students in schools, grades 6 through 12. It focuses on, it's actually implemented through the Project Aware mechanism through SAMHSA, and so states and local education authorities and tribes will have additional funding to support suicide prevention evidence, and students will get it directly. In the past, there was a lot of effort on focusing on training adults that work in school buildings, and unfortunately, that hasn't shown to have the research impact that we need to achieve to make a difference. And so the direct provision of the intervention to students is the idea behind this law, which is evidence-based, which is fantastic. And also, the Bipartisan Safer Communities Act has some additional funding built in for continued dissemination and enhanced dissemination of this Stand Up Act.
Yeah, I love the emphasis on training students. We heard Attorney General Shapiro earlier today talking about how students are, the ones who often know when someone is at risk. So that's wonderful to hear. So I want to ask you both to pick, I know it's hard, but one intervention from your research, from all your expertise on this topic that you think is really promising, that is in the field right now to address youth mental health and suicide prevention.
Sure. So I think one thing that's important to take into account when thinking about these interventions for Latinx youth is just the incredible diversity of the Latinx community in terms of race, ethnicity, in terms of thinking about vulnerable subgroups that we often don't know that much about in terms of our national data. And so thinking about immigrant youth, LGBTQ+ Latinx youth, Afro-Latinx and Indigenous Latinx youth, which is something that can really be addressed most effectively on the local and community level, because communities can really understand the demographics and the needs in these particular groups. And so an intervention that we work on and are really looking to develop further is around integrating community health workers both into community and primary care settings, really leveraging the strengths of people who are embedded in their communities, serve as community leaders or trusted providers who can then support clinicians and other health providers in delivering better care both to youth and their families who often need additional help navigating the mental health care system. And at the same time, there are a lot of challenges to be addressed to be ensured that we create a role for community health workers that is actually a beneficial role for them as well as employees within the healthcare system, that we don't replicate inequities of low-paid providers that are put at a different level in the hierarchy in healthcare. But I think there's a lot of promise to really harnessing the strengths in communities and among families to be able to engage in more effective suicide prevention.
Absolutely. And Holly, an intervention that you're excited about?
Well, it's clear to me, I've been in the field for a long time of suicide prevention, it's clear that we have to attack this problem from multiple angles and perspectives, and we need better coordination. The 2021 suicide mortality preliminary data is available, and we're now up to 55% of suicides were by firearm. So there's definitely, I mean, that would be one area where we could make a great deal of impact. But I think this idea of also coordinating better across funding streams and about people and with people in various disciplines to have a more coordinated and multi-pronged approach would be my ask.
Absolutely. Well, it's great to hear there's a lot of promising ways we can move forward. And we've been talking a lot about Latinx youth specifically, but as we started the conversation, suicide risk is rising for many youth of color. So I'd like to invite Dr. Allison Barlow, Director of the Center of Indigenous Health, to share with us her work tailoring interventions for youth suicide risk in Native American communities. Allison, can you tell us a little bit about what your work in youth suicide prevention looks like?
Yes, thank you, Inari. There's nothing more devastating than a loss of a child to suicide, to a family or community. And we have to feel that in our hearts to do better. Native American youth ages 10 to 24 have had the highest suicide rates in the United States for 4 decades. Suicide is a direct result of generations of racialized trauma that started with colonization. COVID has exacerbated suicide deaths. Native youth now suffer 3 times the rates of suicide than all other U.S. racial groups. Our work with the White Mountain Apache tribe shows there's hope and there's solutions. Over the past 3 years, it has led to the first of its kind tribally mandated suicide surveillance and case management system staffed by local Apache mental health specialists. We've been able to document over a 6-year period before COVID that the system reduced suicide deaths by 38% and attempts by 53%. In addition, through the Bloomberg Initiative, my colleague, Dr. Emily Harrows, sitting behind me, has led our work with the Apache colleagues to develop a highly accurate machine learning tool connected to emergency department data to help flag youth at highest risk. This tool embedded in the surveillance system helps us get to youth most at risk faster. With Native youth suicide on the rise, this work is urgent and there's much to learn from the frugal innovations that are being discovered by Indigenous peoples. Thank you to the initiative for focusing on ending suicide disproportionately affecting youth of color.
Thank you very much, Allison, and thank you, Kiara and Holly, for having this important conversation with us today. I'd also like to acknowledge Bloomberg Fellow Dr. Sadiqa Kendi for her work supporting adolescent health. We heard from Dr. Kendi earlier today, but now we're going to learn about a new project led by Dr. Kendi, supported by the Bloomberg American Health Initiative. In this upcoming video, taking the initiative MASS-PEER, or Pediatric Injury Equity Review. So we'll take a look shortly. Thank you.
Injuries are the leading cause of death in children over the age of 1 in the United States. Unintentional injuries, like traffic injuries and drowning, along with intentional injuries, such as firearm injuries, lead to more deaths than heart disease, cancer, and influenza combined. Despite many years of focused interventions, significant inequities persist in who is injured by race, geographic location, and socioeconomic status. To analyze the root causes of inequities in fatal and non-fatal childhood injuries, and to better understand how to address them, we developed the Massachusetts Pediatric Injury Equity Review, known as MASS-PEER, a new process for reviewing and addressing inequities in injuries. MASS-PEER is led by a multidisciplinary team of experts in injury surveillance, child fatality review, legislative advocacy, and more. The MASS-PEER process was created to be sustainable and scalable, allowing other states and counties to use the process in their communities to review cases with any type of injury mechanism or injury inequity.
Hello, how's everyone doing? So much power in this room this morning. My name is Mika Root, and I'm a Bloomberg Fellow based here in Philadelphia. I work with Dr. Betegal as one of the 7 Bloomberg Fellows she mentioned at the city's Department of Public Health. Specifically, I work in our Division of Chronic Disease and Injury Prevention, also known as Get Healthy Philly, where we work to ensure livable communities, including food justice, joyful movement, and drinking water security for all Philadelphians. Get Healthy Philly started under the leadership of our next speaker. Former Mayor Michael Nutter always got it when it came to public health. Making our city safer and healthier was a top priority, and he and his team made the investments we needed to expand access to nutritious food, make our neighborhoods more walkable and bikeable, and so much more. A lifelong Philadelphian, a champion of public service, and a former DJ, as well as a legislator and executive, please join me in welcoming one of the great ambassadors for our amazing city, the 98th Mayor of Philadelphia, Michael Nutter.
Well, good morning. Mika, thank you so much for that introduction, and apparently you did some in-depth research on that last piece there. It's a pleasure to be with you this morning, and first let me thank Mayor Mike Bloomberg, Ron Daniels, president of Johns Hopkins University, and Dr. Ellen MacKenzie, dean of the Bloomberg School of Public Health, and Jean Weinberg and her entire team. Welcome to the city of brotherly love and sisterly affection, our little town, Philadelphia. And to all of you, the Bloomberg American Health Fellows, all 269 of you, please give yourselves and the audience a big, big round of applause. The 2022 Bloomberg American Health Summit, of course, examines public health's critical, on-the-ground role in working with and on behalf of communities across the country. This year's summit, of course, will also feature some of the great work being done in Philadelphia and other communities as key examples of the power of community-based public health initiatives and what they can do in both local and national levels. Certainly over the past 3 years, public health has been in the spotlight and tasked with addressing national and global crises of an unprecedented level. The importance of local public health efforts has never been greater, and this year's summit aims to bring together practitioners, policymakers, and experts to share ideas and amplify best practices. Through a series of conversations, this event will highlight successful local initiatives, explore implications for national policy, and reflect on the opportunities to continue and improve access and equity in quality healthcare. One other aside. I'll never forget, back in March of 2020, the work that Mayor Bloomberg did to bring together 400+ mayors across the country and around the world to take on the challenge and the crisis of the coronavirus, sharing information, helping others to learn what to do in this incredible circumstance. As was mentioned, I'm a lifelong Philadelphian and a former mayor of this great town, and I'm proud the Bloomberg American Health Initiative has come to our city. And the video we're about to show you will tell you why this is the perfect place to host a live summit for the first time since 2018. Our city, much like this initiative, always strives to help improve healthcare outcomes and save lives, especially of our most vulnerable citizens. And so, let's go. On location, Philadelphia.
Hello, everyone. Welcome back from break. I hope you enjoyed those wonderful snacks. You got to stretch your legs, move a little bit. Hi, my name is Charles Hawthorne. I'm a fellow in addiction and overdose from Oakland, California. Very long flight here. I work at California Bridge, a program of the Public Health Institute. At California Bridge, we are working to help emergency departments all across the state and the country build substance use treatment and harm reduction programs with the goal of having 24/7 access to substance use treatment and high-quality care for people who use drugs. I'm really excited for our next panel. In my role, I help advance our harm reduction and racial equity work and support hospitals in building that out. And I'm looking forward to our next panel because upcoming Supreme Court decisions have a really huge impact on the public health work we do all across the country. Laws such as the Emergency Medical Treatment and Labor Act, ADA, Title VI of the Civil Rights Act of 1964 have a huge impact on how hospitals operate and the care they're able to provide. And I'm really excited to hear from our panelists. Please welcome journalist in residence at Johns Hopkins Bloomberg School of Public Health, Joanne Keenan, in conversation with Justice William J. Brennan Jr., Professor of Law at Georgetown University Law Center, Lisa Heinzerling.
So Lisa, the Supreme Court ruled on 4 really landmark cases that I understood the implications for public health, or I thought I understood the implications of public health before I met you, and you told me, there's a whole other layer. So one was obviously the Dobbs case, the abortion case. One was the New York State gun control, striking down the New York State law. One was the West Virginia EPA case, limiting the EPA's power to regulate fossil fuel power plants. And then the final one was the case saying that large employers cannot require COVID vaccines, or the COVID vaccinate or test policy that large employers were doing, that OSHA was trying to do. So those are very different. They all have huge implications of public health. I looked at them individually. Oh, this is bad for public health, this is bad for public health, this is bad for public health. But you saw something larger, so explain.
Yeah, I mean, the surprising and disturbing thing that aligns all of these cases, which are all about public health in a fundamental sense, all have enormous consequences for public health. But one of the alignments among them is that the Supreme Court actually didn't engage with or really even talk about the public health consequences of those decisions. It really wasn't interested. In a couple of cases, it explicitly said that's not our job to think about those consequences. One might have said it's not your job to do the thing you're doing without thinking about those consequences either, right? So there's they're all about public health. They all refuse to engage with the serious and in many cases immediate public health consequences of the decisions. And in addition, they all deployed very assertive, I would probably say reckless, understandings of the federal Constitution. Right? And so that means that they are constraints in a way that decisions interpreting statutes on their own without constitutional overtones are. Other decisions that can be redone, these cannot easily be undone.
So it's not only I as a justice am going to try to time machine myself back to the 1790s and figure out what the founders would have said. I am actually not going to pay attention to the real life consequences on the health and actual lives of people living in the 21st century. So you've defined, there's something called the major question that you've written about, that how the Supreme Court defined a major question, and then you've also written about the minor question, which is, I think, your coining. Explain what a major question is, because people are going to be hearing about this more.
Yeah, I think this is really important. If you take one thing from this panel, is just that you might want to pay attention to what the Supreme Court is doing in all of your work, because this is an incredibly consequential kind of new doctrine, just named really by the Supreme Court for the first time last June. Right? And so the major questions idea is a way to interpret a federal statute. Most federal statutes, all the ones I've heard about this morning on the federal level, in most of them, on all of them actually, Congress takes on a problem, infectious disease, air pollution, water pollution, you name it, and describes outlines for dealing with that problem, and then hands it to an administrative agency, the Food and Drug Administration, the EPA, the Occupational Safety and Health Administration, and so on, to complete the work, right? And those agencies are experts in ways that Congress isn't. They can act quickly in ways that Congress can't. And so Congress, that structure is true of almost every public health statute I can imagine and know. Right? What the court has said is that if Congress wants to do that, if it wants to empower an administrative agency to take on an important problem in any field, outside public health too, in any field, it needs to speak clearly in giving that agency power. Right? And by clearly, it doesn't just mean that the statute literally allows the agency to do something to address a major problem that Congress has identified. It means it has to speak quite precisely about that problem as well. So to take the vaccine or test mandate issued by the Occupational Safety and Health Administration, you would think that that statute fit that like a glove. Here was a workplace hazard that was serious, that the agency is empowered to take on serious workplace hazards, and the Supreme Court said, no, not clear enough. And so the idea that there's a plausible basis for the agency's power is no longer enough. Congress needs to speak really clearly. And what's an important problem? What are the kinds of important problems that Congress might act on where it needs to speak really clearly? Well, here's the rub. It's the kind of problem that the conservative justices on the Supreme Court think is really too big for an agency to handle without crystalline, clear language from Congress. And you're probably thinking, oh, there must be something more to it than that, right? Is there something more to it than that? Yeah, the court mentioned a couple of factors in each of the cases. The statutes, in many cases, were fairly old. The agency was acting in a new and creative way, right? But the bottom line is, it's called the Major Questions Doctrine because of the importance of the issues. And those are important because of economic and political considerations that are quite subjective.
So is this thing Congress can fix? We're out of time, but yes, no. Is this easy for Congress to fix?
No.
You could have guessed.
That's the rub, too. Can I just take 1 second to say why? In theory, sure they can. Sure they can fix it, but they need to be super clear in a way that's obvious to them when they act, which might be years before the Supreme Court decides any case involving it. And again, the structure of the public health laws that you really care about is to take a problem in advance, identify it, state the factors relevant to the agency, and then empower them to act even when it emerges suddenly, and to create solutions that are resourceful and new. And those are the things that the Major Questions Doctrine really disempowers Congress and the agencies from doing.
Well, that's all the time we have. We're going to change gears now and look at some really interesting work and a video being done by faculty involved with the Bloomberg American Health Initiative to support the work of the federal agencies. So here's more. Thank you.
The Bloomberg American Health Initiative is supporting our faculty to work inside the federal government. This gives them the opportunity to impact health across the country. Let's hear from a few of our participating faculty.
At the Administration for Children and Families, I support policymaking to help children, youth, and families affected by overdose and addiction. This work has allowed me to advance equity in communities affected by adversity.
I began my one-year project with the CDC's National Center for Environmental Health in August of this year. I've been working with senior policymakers there to focus strategic planning on climate change and health.
My appointment with the White House Office of National Drug Control Policy allowed me to work side by side with officials in the Biden administration, informing priorities from the National Drug Control Strategy. It was a privilege to work inside the White House to save lives from overdose.
The great work of Dr. Latshaw, Dr. Cepeda, and Dr. Powell is just the beginning. At the Bloomberg American Health Initiative, we're so proud to support these faculty as they make an impact across the country.
Please welcome back Dr. Joshua M. Sharfstein.
How's it going so far? Okay, excellent. So I remember my first impressions of our next speaker, who is Dr. Rochelle Walensky, the director of the Centers for Disease Control and Prevention. I could tell she was very smart, had a great positive attitude, and was going places. And by going places, I mean I think her mom was going to take her to the Cabin John shopping center. We were in 3rd grade. Now, Rochelle and I remained friends through high school and beyond. I particularly remember 6th grade because Rochelle was the tallest kid in the class, and I was the shortest kid in the class. And Rochelle did go places. She trained in medicine at Johns Hopkins before moving to Harvard to study infectious disease and focus on HIV. She became not only a leading researcher, but also a leading advocate for equity and access to treatment, and particularly treatment for women all over the world. At CDC for 2 years, Dr. Walensky has held, in my opinion, the most difficult job in public health ever. She has stood tall in a storm of misinformation. She's begun the difficult work of acknowledging shortcomings and fixing the CDC, and she has spoken with honesty and integrity again and again to the American people. Please welcome Dr. Rochelle Walensky, someone I have looked up to both literally and figuratively for a very long time.
Wow, good morning. I am delighted to be here. Thank you, Dr. Sharfstein, for the invitation to speak, for your leadership as the Vice Dean of Public Health Practice and Community Engagement at the Johns Hopkins Bloomberg School of Public Health, and for your leadership as a key member of CDC's Advisory Committee to the Director, helping our agency prioritize our activities, address health disparities, and chart a bold course for the future of public health in America. I am honored to have called you my friend, truly, yes, since, well, I would say the 2nd grade. I think Josh said the 3rd grade. I've been referring to the pandemic as the Superman moment of public health, our Superman moment. In the spring of 2020, we were going about doing the good work of public health. Then, a dizzying moment. We were called to enter the phone booth, to don our capes, and to emerge with the tools to fight COVID. The spotlight was on us. And while we had knowledge and we had experience, we didn't have all the answers. But in our figurative capes, we, the public health community, stood together to confront the most enormous public health challenge of our lifetimes. Indeed, I believe this COVID moment that demonstrated the importance of public health, our added value, our steadfast nature, our quiet expertise, is what is motivating so many more people to enter the field, energizing the next generation of public health leaders. The challenges of the COVID-19 pandemic made us acutely aware of the urgent need to create public health culture that is nimble and one that puts health equity at the forefront of our actions. I want to spend the next few minutes talking with you about the subject of data, the essential foundation of good decisions. Public health is a data-driven effort. Data must move at the speed of need, not at the speed of bureaucracy, especially in times of crisis. We must have timely and quality data to monitor disease levels, to track and analyze health trends, and to measure the results of our interventions. Now, while everyone is watching, we must take advantage of that attention and put in place the changes that are needed. At CDC, we take very seriously our responsibility to analyze and share data quickly, to transparently share the data upon which our decisions are made with our public health partners and with the American people. but we can only report the data we receive. CDC does not have direct authority to require data reporting. Headline after headline calls on us to report information on X or on Y. But let me say it again. CDC does not have direct authority to require data reporting. We receive data from 50 states and more than 3,000 local jurisdictions and territories. Each has its own data sharing agreement with the CDC and its own data sharing agreement sometimes with each other. It is up to each city, county, state, tribal nation, and territory to decide what information is collected and how it will be shared. Then the data arrive at the CDC in a variety of formats, from automatic electronic data exchanges to Excel spreadsheets to forms on paper. And the speed at which the data are delivered varies because each jurisdiction has its own systems and capabilities, and many are quite antiquated. Some are still working on 1980s fax machines. All of this must change. For example, real-time data on firearm-related injuries, including information on the intent, location, relationship to the shooter, and circumstance, is critical. Yet, CDC only has the authority to aggregate data at the national and regional levels, not at state or local, with some few exceptions. We have no statutory authority to require data collection on youth risk behaviors or evidence-based school health policies and practices. Without this authority, it's a struggle to get full participation and the data needed to develop programs supporting the health and well-being of our students. Recommendations on how to change poor health outcomes caused by conditions such as hypertension and diabetes are hampered by data that come to us slowly, sometimes months or even years after they are collected, and without information in all of the fields. And when we face the Mpox outbreak and our public health partners and public expected CDC to rapidly report on who was being vaccinated and how many cases were being reported, our lack of data authorities meant our state, local, tribal nation, and territorial partners were not required to provide us that information quickly or even at all. I've spent considerable time on the Hill speaking with members and promoting the recent legislation introduced by Senator Tim Kaine and Representative Lauren Underwood that will provide CDC and public health writ large a modern policy tool to create uniform data standards that local, state, tribal, territorial, and federal health systems would all use, providing secure access to data in a standardized, timely, and coordinated way. This will mean better data, faster data, and reduced burden on data providers. CDC's Data Modernization Initiative is working to modernize our technology while putting the right people, processes, and policies in place to deliver real-time, high-quality information. Our Data Modernization Initiative is about making sure our data highways connect and that the traffic is free-flowing. At the beginning of the COVID-19 pandemic, we had no national system for tracking positive and negative laboratory test results. So we created a new pathway for laboratory data through COVID electronic laboratory reporting, capable of delivering more than 1 million test reports per day. Keep in mind, before COVID, reportable diseases came to CDC at the frequency of a measles or Legionnaire's outbreak. When we began collecting data on COVID cases, only a handful of healthcare facilities were even capable, of sending electronic case reports. Now, thanks to our partnership with the Association of Public Health Laboratories and the Council of State and Territorial Epidemiologists, more than 20,000 healthcare facilities across all 50 states are exchanging automated, near real-time critical patient data with our national public health jurisdictions. And while this is amazing progress, 20,000 healthcare facilities is only a fraction of the total, representing only 22% of the hospitals registered for the Centers for Medicare and Medicaid Services and 9% of rural health clinics. We have much more work to do. Cloud-based platforms give us the capability to deal with the millions of lab records received each day. the more than 530 million unique immunization records processed in the past year, the almost 2 million SARS-CoV-2 sequences, all numbers we have not seen in the history of public health. We want these data to come to CDC quickly, and when they do, we want to deliver them swiftly back to you so that you can see what is happening in your area and, importantly, the areas around you. We're improving the data collection of equity-related data. For instance, our ability to capture race data from COVID-19 related emergency department visits has grown to 93%. And we continue to work with hospitals and onboard new hospitals to continue to grow that number. Data from emergency department visits are important for monitoring public health events that would otherwise present to an emergency department, not just COVID, but influenza, RSV, Mpox, many other infectious diseases, overdose and other injuries, suicide attempts, heat-related illness, and so much more, and how patterns vary by demographics, they vary by time, and they vary by geography. We're adding modules for social determinants of health to our surveillance systems for behavioral risk factors in pregnancy to help us track topics such as food and housing insecurity, transportation access, social support, well-being, and economic stability. And in a way that absolutely protects personal identifiers, we're collecting more specific non-health data on smaller populations that have historically been underserved and underrepresented in the data. For example, using vital statistics and census data to develop a mortality profile for American Indian and Alaska Native communities. As you say, data modernization is not just for outbreaks and pandemics. To help us use data to identify and prepare for future threats and to translate and communicate what we are learning more effectively, in August of 2021, we launched the Center for Forecasting and Outbreak Analytics. This new center is strengthening the nation's early warning systems for health threats, bringing together next-generation public health data, expert disease modelers, public health emergency responders, and communication experts to work towards never facing another public health emergency unprepared again. We have had a very hard 3 years. And when we started, we were undervalued, misunderstood, and frail. And yet, I see this as an incredibly exciting time for public health. Our public health community is using this momentum provided by the pandemic to build a public health workforce and system prepared for the challenges to come. Not only by developing and deploying world-class data and analytics, but by investing in core infrastructure, including maintaining state-of-the-art labs, responding to international and domestic outbreaks at their source, and strengthening our global capacity and domestic preparedness. Now, before I leave you, I'm going to put on my CDC and infectious disease hat and mention that it's National Influenza Vaccination Week. And remind you that if you haven't gotten your flu shot this season, now is the time. And while you're thinking about vaccinations and talking to your family and loved ones and friends, have you received your bivalent booster? Fewer than 33% of those over the age of 65 have gotten their shot. And the number protected with the bivalent vaccine decreases with age, with just over 8% of those 25 to 49 having gotten their updated dose. With the elevated levels we are seeing of respiratory viruses this year, these vaccines can be life-saving, especially for those at highest risk. So it's not too late to get your vaccination. To each of you here today, please know how grateful I am for the work that you do, the effort that you put in, and the commitment that you have to our field, our science, and to the public health mission. Thank you very much.
I'm Danielle Nabak, and I'm a Healthy Communities Coordinator for the University of Wisconsin Extension FoodWise program. In my role, I'm focused on policy systems and environmental change efforts that support community food and health systems here in Milwaukee and across Wisconsin. I'm most interested in supporting collective action and community partnerships that emphasize the connection between food, health, and other variables like education, housing, economic development, environment, and public safety. With a background in organizing and a passion for connection, I bring folks together to overcome siloed sectors and bring community voice to the table so that residents are leading food systems change. In addition, the multidisciplinary nature of the Bloomberg Fellowship aligns with Extension's priority to bridge disciplines to inform our most pressing societal problems and create community change across Wisconsin.
Hi, everybody. My name is Tessa Mork, and I'm a Bloomberg Fellow studying obesity in the food system from Washington, D.C. In D.C., I work at the YMCA of Metropolitan Washington. In my role, I work as the Association Director of Community Health, where I oversee our chronic disease programs as well as our SNAP-Ed program, which provides hands-on culinary and nutrition education to over 3,500 SNAP-eligible community members in the district annually. I'm looking forward to this upcoming panel because food and beverage advertising is an equity issue that comes up often in our work and is near and dear to me. Please welcome Emeritus Professor of Epidemiology at the University of Pennsylvania Perelman School of Medicine and Research Professor of Community Health and Prevention at Drexel University Dornsife School of Public Health, Dr. Shariki Kumanyika. Community advocate and enthusiast, Camry Moses. Immediate past present at the Maryland Academy of Nutrition and Dietetics, Teresa Turner, and your moderator, Professor and Chair, Department of American Studies at the University of Maryland, Dr. Psyche Williams-Forson. Thank you.
Thank you. Developing effective food policies which promote health and equity requires historical, cultural, and economic perspectives, right? It also involves addressing and confronting systemic barriers to achieving equity, as well as social determinants of health need to be confronted. A lot of this work is already being done through organizations like Operation Good Food and Beverages, which works to empower Black youth to recognize the history surrounding the food system and spark a good food revelation, or revolution and revelation. You recently conducted research on ethnically targeted marketing of unhealthy foods and beverages, Dr. Kumanyika, through this organization. What would you say is your biggest takeaway?
Well, first I'll tell you a little bit about the project that we did. It was really exciting, an opportunity to create a new approach to a really important food justice issue. The issue is the disparity created by the way unhealthy foods are marketed to Black communities and Black youth in particular, so that it exposes the youth, for example, to messages and settings that really promote unhealthy diets. So the typical approach to doing this is to talk about how companies victimize people and so forth. And we decided that while that approach may have its place, we wanted to flip the conversation to something positive and lift up the voices of Black youth as powerful consumers who were demanding healthier foods and beverages. And so we created this campaign called Operation Good Food and Beverages. We have a website, Instagram, TikTok, and a petition. The petition is to the National Restaurant Association to sit down with us and talk about the possibilities and realities of getting healthier food onto main menus, because teens and youth, they don't eat from the kids' menu, they use the main menu. Our biggest takeaway was that a positive message is really well received, even though people are skeptical that it can work. We feel that it can work when youth raise their voices and put it in their own words that they want healthy food and want to be, to really have that, the marketing shift more towards the healthier foods and beverages. So we hope that Operation Good Food and Beverages will be the viable start for a long game in this way.
Thank you, thank you. And Ms. Turner, in your role as a school nutrition specialist, you have seen some of these issues come to the fore. What is it that you want to share with policymakers today?
One of the main things, I want to shift the view of what a policymaker is. We're all policymakers because we either vote for those who make policy or we vote for people that appoint people that make policy. So rather than focusing on, and it's very important to focus on all of it, but the focus is always the people in Congress or the people in those positions. Focus on your neighbor. Focus on the people you see every day. Focus on shifting the mindset, because the mindset is what causes people to vote the way they vote and choose the way they choose and have the view sites and sites they have on things. And it's all part of a cycle. It's not a vacuum. When we see certain perceptions and we see marketing and we see how things are portrayed in the media or in our neighborhoods, that is how we come to these conclusions, and that's part of our implicit and explicit biases. We come into these conclusions that, oh, the policy should be this because these people may not deserve this, because that's what we see and that's what we're surrounded in. It's capturing it right in the middle and stopping the cycle where it is and saying, maybe my perception is based on something other than reality, and let me think critically and then talk to my neighbors about what policy we want to make going forward.
Good, good, thank you. And Cam, as a young activist, what would you say has been the most important lesson you've learned about enriching your community from creating your own food-based nonprofit, KR Smoothies?
So I would say with my community work and the work that I've been able to do with KR Smoothies is, in order to convey these heavy messages, you have to really take the time to empathize with the people that you're trying to communicate to and be really intentional about the time that you are taking to connect with these people. Because if you don't understand them or meet them where they are, then you will not be able to convey that message to them. So just being really intentional about the space and time that you take up with the communities that you serve.
Awesome, thank you. Thank you. Wonderful, thank you, panelists. And with that, we're actually wrapping up our focus on obesity in the food system, moving toward our final focus area of environmental challenges, the pursuit of environmental justice. But before we do that, we're gonna end with a word from Chef Jose Andres, who is not with us live, but actually who is on location in Ukraine with his team from World Central Kitchen. But we're gonna end by hearing from Chef Jose Andres.
Hello, people of the Bloomberg American Health Summit. I am Chef Jose Andres. Thank you for being here today. The topic of food policy, equity, and health has never been more important to me, to America, and to the world. Food should be part of our lives to nourish our bodies and our souls, not to make our communities sicker. And food policy should have a positive impact in all communities, making sure that food deserts and food swamps become a thing of the past, making sure children in the schools have access to universal, free, healthy meals, enriching and revitalizing communities instead of leaving them hungry and poor. This past September, I was so proud to co-chair the White House Conference on Hunger, Nutrition, and Health, the first of its kind in over 50 years, where people from all walks of life, government, private sector, nonprofits, people with lived experiences from all parts of the country, came together to declare that food should be a national priority, not an afterthought. And that health and equity have a vital role to play in the future of how we feed our country and our world. Thank you to everyone involved in today's event, especially the Operation Good Food and Beverage Project, the Council on Black Health, Heart Smiles, and of course, the Bloomberg American Health Initiative. The conversations you have today will impact the work we all do tomorrow. And together, one plate of food at a time, I know we can create a healthier, more equitable America. Thank you very much.
My name is Michelle Mapson, and I'm a staff scientist in healthy communities at Earth Justice. Earth Justice is our nation's largest nonprofit, public interest environmental law organization. And in my role, I work to provide technical and research expertise on environmental health and risk assessment to help inform our litigation and advocacy efforts. The Healthy Communities team works to hold polluters and the government accountable so that communities do not face undue harm from air and water pollution or exposure to toxic chemicals or waste. I work alongside other scientists and analysts, attorneys, policy experts, and communication strategists to help to advocate for stronger federal and state-based health protections. Recently, my team has worked to urge the Environmental Protection Agency to strengthen the lead and copper rule. And because of our efforts, new proposals are beginning to address the need to better protect children from the neurodevelopmental harm caused by lead, which is a major step forward. One of the reasons that I was attracted to the initiative is because of its emphasis on tackling climate-related challenges. As a Bloomberg Fellow, I have the support of my organization and the incredible opportunity to collaborate with other fellows and their organizations, professors, and staff to address the environmental challenges that affect the communities that I work with.
Please welcome founder and executive director of the Environmental Justice Coalition, Ruhi Goswami, in conversation with the director of the Bullard-Centered Environmental and Climate Justice at Texas Southern University, Dr. Robert Bullard.
Hello, everybody. Can you see us? I can see you. This is a conversation between a Gen Zer, Zoomer, Ruhi, and myself, a Boomer. Proud of it, still standing. So let's get into it, this intergenerational conversation, quickly. First, I have a question, Ruhi. Growing up in the age of climate crisis and the urgency of what's happening today, how do you see your work changing, and how do you get more young people involved in this movement?
Yeah, so this is a question we get asked a lot, and I think the biggest thing to emphasize is the fact that the climate crisis is what actually propelled us into this movement in the first place. My interest in environmental justice stemmed from seeing these crises happen in marginalized communities, as well as talking to these communities and people who are directly involved in the work of these communities. Climate anxiety, although very eminent and frightening at times, is what's propelling these youth to create some unique solutions, create amazing nonprofits and work, and really use their voice to do things. And that's what the climate anxiety and a lot of these climate crises have caused. And empowering youth to bridge the generational gap and help them understand important topics like environmental justice. Often when we look at inspirational figures like Dr. Bullard, we wonder how these communities who have experienced so much trauma from climate change, so much grief, how do we help them as youth, and how do youth understand all these traumas and still have hope at the end of the tunnel? And empowering youth, what does that look like? That looks like mentorship. As public health professionals, the best thing you can do is extend your hand, extend your network, and show youth that there is a path forward. And not only public health professionals, it can be anyone. And as Dr. Bullard told me, it's extending a baton as if like in a relay race between the generations. And he's run it for so long, and having that hope that the next generation will pick up that baton and continue running and have that stamina, have that endurance to propel themselves through the movement and have that hope as well. It's seeing that people trust our voice, trust our knowledge, trust the solutions we have and the things that we bring to the table that really empower youth. And it shows youth that you don't necessarily have to be involved in policy, advocacy, be grassroots activists. Don't have to be a STEM major. You can be in marketing, graphic design. Climate change is such an intergenerational, it's an interdisciplinary movement, really. And it's just showing youth all of these things that helps empower them. So Dr. Bullard, I have a question for you.
Oh, okay. You had all the answers.
I'm sure.
Thank you.
As someone so pivotal in this movement, as we love to call you the father of environmental justice, how do you think that the work of environmental justice has changed throughout the 3 decades you've been involved? And what has stayed the same, whether it be in pop culture, media, how we talk about environmental justice?
Well, I started way back in 1979 when environmental justice was not even a concept. It was a footnote. And over the 43 years, it's a headline. And I think the progress that we made is about time in terms of having a cross-disciplinary movement, intergenerational movement, young people, having it, the issues integrated into the curricula, college and universities, every program. And I always say any academic program at a university that does not include equity, justice, fairness, environment, and health is inadequate. So we have to make sure, thank you, we have to make sure that these issues resonate across. There is no health equity, environmental justice without racial justice. We see that happening every day now more so than ever.
Absolutely. So especially because we can see how throughout becoming headlines and environmental justice is becoming more mainstream, that's why we need to have these conversations between generations to make sure that the fight grows, the fight continues, and that we can bring more people into understanding that racial justice is for all communities, as well as, and uplifting these marginalized communities is the best thing we can do as public health professionals, as well as to improve equity and diversity within the public health field as well. So,
yeah, so good student, good student. The fact that we have now so many young people working on these issues without all these wedge issues driving us apart. What brings us together is fairness, justice, and equity. I've written 18 books over the last 40 years. It's 18 titles, but it's just one book, but don't tell anybody. The fact is, it's housing, transportation, energy, food and water security, transportation, and health. Health is at the center of all of that. Last word.
Yeah, so what drives you and what keeps you hopeful for the future of environmental justice?
Well, young people. The fact that we cannot get this movement moving across without having young people, without having science, without having data, without having people understanding that we do not need false solutions. Oil and gas, petrochemical industries have created so much havoc on this earth, and to have, beyond petrochemical campaigns, to have issues around fairness, justice, transitioning to a clean energy economy, that's where we need to go. That's what's needed today.
We also need to educate youth, as well as Dr. Bullard has mentioned, academia especially, these spaces need to be expanded to encompass environmental justice, to encompass public health, equity, diversity, and inclusion, include voices that we haven't heard before, indigenous scholars, Black scholars, Latinx scholars, and we all want to see this. As a person in college, I would love to read more diverse literature, and that's what's most important, is diversity in education as well.
Very good. She has the last word. The clock is clicking at 0. It's time for lunch. Thank you very much.
Thank you.
Please welcome back Dr. Joshua Sharfstein and Michelle Spencer.
That was awesome. Thank you.
That was incredible, don't you think? Yeah. Would you agree?
I kind of wish we'd done the survey. Because then we'd have quantitative data about how it's gone so far.
There will be a survey, Josh. Just not the kind that you're expecting.
Everyone should know there's a QR code outside. You can do the survey afterwards. If you think I'm kidding, you will find the QR code outside and you think about that. Okay, let's move on.
Well, before I forget, there are breakout sessions this afternoon. We are looking forward for you to join us in those breakout sessions. They begin at 2 o'clock this afternoon. If you are choosing the off-site trip, please meet at the help desk at 2 p.m. If you're not sure which breakout you're in, please check your emails for confirmation, or see Josh, he'll have the survey end. Lunch is from 1 to 2 in the Millennium Room, so please make sure you avail yourselves to that.
Great. We want everyone to realize, of course, that incredible events like this do not produce themselves. We want to really thank so many people who have helped us, not only with the production of the day, but all the work that's gone behind it. We want to do a special thank you to Jessica Layton of Bloomberg Philanthropies. But also to Production Glue, Subject Matter, the wonderful team here at Lowe's, and our initiative team. One more round of applause for everybody. You know, it still feels like we're missing something, though.
Just one last thing. Before we go, we are on location in this historic city. So why don't we make it a historic day?
Please join us in welcoming 2 initiative team members, the producer of this event from the initiative, Shannon Jones, and Shane Bryan.
Thank you.
(1776), Philadelphia. The Declaration of Independence. All men are created equal.
A founding document for this country, freedom from the monarchy. But all men are created equal? Really?
Women weren't included. And Thomas Jefferson, he didn't mean all men. He enslaved people himself.
Y'all, the Declaration of Independence refers to indigenous folks as merciless Indian savages.
So I guess they didn't mention the part about the nation being founded on stolen land, right?
Y'all, I wish we could have a declaration for all of us.
A declaration that brings us together. Maybe we can.
2022, Philadelphia, a declaration for all of us. A declaration about our connections to one another. A declaration of interdependence.
When in the course of human events, it becomes necessary for people to recognize all that connects them to each other and to the environment, it therefore makes sense to declare this interdependence and work together to bring about health and equity for all.
We hold these truths to be self-evident, that all people have the right to life, liberty, and the pursuit of happiness.
That life, liberty, and the pursuit of happiness rest on a foundation of health.
And that our health depends on what we as a society do collectively to assure the conditions for people to be healthy, of the very definition of public health.
Prudence indeed will dictate that people should take actions to protect their own health and well-being. But when it is asserted that health is only an individual's responsibility, regardless of the means and opportunities available to them, it is the right and it is the duty of people committed to public health to respond. Here are some facts to submit to a candid world. These include:
elected officials have forced health experts from their jobs for telling the truth about how an infectious disease spreads. Organized campaigns have sought to deny the existence of structural racism and health inequity, despite manifest evidence that their profound impact on health and well-being.
State legislators have passed laws limiting the authority of health agencies to protect their communities during emergencies. The Supreme Court has curtailed our efforts to respond to gun violence, climate change, COVID-19, and other urgent threats. The U.S. Congress has yet to provide a sustainable source of funding to support core public health functions at the state, local, tribal, and territorial levels.
We have protested in the most humble terms, but our petitions have yet to be answered satisfactorily.
We, the undersigned, therefore, as attendees at the 5th Bloomberg American Health Summit in Philadelphia, Pennsylvania, do today declare our interdependence.
Health depends on access to support and care for mental health and substance use disorders. Health depends on child and adolescent health, on oral health, and reproductive health. Health depends on essential resources, including quality education, nutritious food, and adequate housing.
Health depends on stopping hatred, racism, and discrimination in all its forms. Health depends on social justice.
Moreover, the health of humankind depends on the health of our planet.
The health of one country depends on the health of all countries.
The health of one community depends on the health of all communities.
The health of each of us depends on the health of all of us.
In Lakota, there is a saying, Mitakie Oestin, we are all related.
For the support of this declaration, we commit our partnership, our leadership, and our fellowship on this day, in this space, at this historic location.
attending the 2022 Bloomberg American Health Summit. Please proceed to lunch in the Millennium Room.
Hey, thank you so much. Hey, we did it,